board members to our board meeting held in public. And very much can I welcome the members of public and staff who I know join us for these meetings. We've got agenda today that is going to be a challenge for all of us. So I will be grateful for people sticking as best we can to our etiquette, muting mics if not speaking, introducing reports as briefly and succinctly as possible, please. Questions we'll take after the speaker has finished. We're going to keep trying to avoid the use of acronyms, and we haven't got any fire alarms planned for today. And members of the public, I know you are aware that any questions that you have about items on today's agenda can be raised using the Q&A function. They'll be reviewed by our company secretary as per the protocol, and they will be taken at item 19. We will conclude today's meeting rather later than normal at 5:15. And because it's a long meeting, we have built in 3 breaks at approximately 10:45, 12:10 and 13:45. So my apologies for a long agenda. I don't have apologies for absence from any of our board, but I do have apologies from Uzma Bazai, who is our next director, who is normally in attendance. And before we start proper, I have great pleasure in welcoming you, David Allen, who is going to be our chairman from the 7th of January next year and is here observing the meeting today. Thank you very much for coming and being with us. I'd also like to welcome Matt Hill, who is our new non-executive director. This is your first board meeting. You're very welcome. And I'd also welcome Meredith Kane, and you like to be referred to as Mary, who is our Chief Medical Officer, and this is your first meeting of the board. So I might as well warn you now that when we get to the point where we review the board, I look to brand new members for comments because you've got that lovely fresh eyes view. So be prepared. We'll be coming to you for some comments. We have a number of other colleagues joining us for time to business during the meeting. Megan Nichols, who's our patient experience manager, and Jane Mitchell, our complaints manager. Sarah Coulter, who's welcome and often here, guardian of safe working hours. Joe Burton, our freedom to speak up guardian, always welcome. Sarah Jarvis, our consultant in critical care and lead for organ donation. Lawrence Moulton, Director of Medical Education, and should it be required, Jill Derrick, our Deputy Medical Director, will be joining us as well for various parts of today's agenda. So that was a long introduction, sorry. Are there any declarations of interest relevant to today's meeting? No, I don't think so. Thank you very much. And could we then come to the minutes of our meeting, previous meeting, which we have for the 5th of September and the 19th of September. Are there any matters that you need to raise in terms of the minutes? No, and then you have the action log with the detailed update. Are there any questions on the action log? No. Are you happy then that we accept as complete those proposed complete? But I just nods would help me. Thank you very much. That's great. That brings us then to our item 5, which is our board story. And I'm hoping that Kim is online. She is. Well done, Kim. We're getting connected. If I could then please invite Kim O'Keefe, our Deputy Chief Exec and dual Chief Nursing Officer, to introduce our board story. And just for the benefit of members of the public and new members, we always have a board story of either a patient or a staff story. And we always have it first because it's what we're here for. And with all the other busy business that we have, it's just nice to remind ourselves and be reminded of the reasons that we're all here. So Kim, thank you very much.
Thank you very much, Madam Chair. So today I thought what better time than to as we have our annual complaints report with us, to have a look at what did our complaints tell us? And most importantly, when people were telling us things, what did we do? And I think we've also got Megan Nichols, who is our patient engagement manager, and Jane Michelle, who's one of the lead for patient experience and complaints with us today as well, to answer any questions. Next slide, please. So I will play the video. It's really important. If you go around our hospital, you will see our Know How You're Doing boards, and part of every Knowing How You're Doing board has a section that said, "You said, we did." So if we could play the video, please.
During Q2, the patient experience team received a total of 435 complaints. 73 of these were formal, and 64 of them were upheld or partially upheld. The complaint themes that were highlighted to have an increased percentage compared to those in Q1 were admissions, discharges and transfers, prescribing, facilities, appointments, and trust administration. The top 3 themes were communication, clinical treatment, and patient care. We have an example from each theme with the actions and learning that came from the complaints. You said, we did. You said,
the medication remained by the patient for several days before it was noticed by a nurse after the family member had brought in some other meds that had been overlooked. When it was pointed out that the other medication was still on the side table next to them, the nurse took both sets away to lock them up after saying that they shouldn't have been left there. The patient, who has dementia, could have taken the tablets without knowing the quantity needed, or another patient could have access to them.
we did. Included in the next safety brief was a reminder to all staff that medication should be locked away in the treatment room for high-risk patients. You said the patient had developed bruising around their face.
The nursing staff were asked how the bruise had occurred, but no one knew, so the family asked that the patient records were looked at to see if it had been recorded how the bruise had happened. It looked as though someone had forced the suction tube into the patient's mouth and they had encountered serious difficulties with secretions. When the family member tried to use the suction device, the tube to the container immediately fell off when touched. They felt lied to, as the patient did not need suctioning and the tube did not work anyway.
We did. The ward sister will ensure that all staff are given refresher training around replacing the suction equipment when used, and will highlight to staff to make sure extra care is taken when suctioning patients. You said,
prejudicial, detrimental comments of the senior nurse are totally uncalled for. They are clearly in the wrong job and need some disability training.
we did. The ward sister will ensure that all staff on the ward have completed equality, diversity and inclusion training. You said,
The patient is supposed to have annual hip x-rays alongside their CPIP to monitor the ongoing displacement of their hips. For the third time since 2020, no one referred the patient for their x-ray this year. The family are incredibly upset that this has happened again and don't understand how a referral for an annual x-ray can be missed so frequently. Can someone please inform me as a matter of urgency what the pathway is supposed to be for referring annual x-rays for children? If your official policy is that it is the responsibility of parents to request the x-ray when it is due, please can you make this clear so that they know in the future that it won't happen unless the family request it? If this is not the official policy, then please explain whose responsibility it is to request the x-ray and how that department is going to ensure that the patient's annual x-ray is not forgotten again in the future.
we did. The CPIP database will be updated to indicate the date that the x-ray is ordered and completed. A new Children's Community Therapy Service CPIP pathway to include the ordering of x-rays is being developed. You said,
Since chemotherapy, starting in May 2024, the patient has been suffering with many side effects. In an appointment with the CNS, the patient initially spoke with on the phone in February was followed by a letter that stated, tolerating chemotherapy with no significant symptoms or side effects. This letter is entirely inaccurate.
we did. The team will audit our clinical letter templates to minimize any inconsistency in content and consider adjusting future letters to give a reflection of what the patient said and the reason for no further supportive subscribing or treatment adaptations when applicable. You said, we did.
Thank you, Pete, and welcome, Megan. I don't know if you'd like to add anything to that, and thank you to you and the team.
Yeah, I think it's just really important to we see the complaints come in, and we don't always see the outcome from it. So I think it's really important to showcase that and show the work that the care groups are doing off the back of complaints.
Thank you, and as we all know as a board, and we'll see later in the complaints report, some further details on how we have managed that and what our ambition is as we move forward in the year. Thank you, Mari. I'll open to questions.
Thank you very much. And can I give special thanks to you, Megan? It must be an incredibly difficult job to spend a lot of your time listening to complaints and then handling them as well as that I know you do. And I do also read Care Opinion. I'm always very impressed how rapidly we respond. But it's a hard job to do. So thank you for doing it. And thank you very much for the presentation. I've got a number of people who would like to speak. And I think, Richard Cramer, you were first.
Thank you very much to both of you. And it's first of all, it's really important to be open and transparent about our complaints and how we respond to them. So I really got that from hearing you, Kim. I just got one question, and I've read this in conjunction with the complaints report. I just want to know if you're, Megan, if you're satisfied that each and every time learning is taking place in each of the care groups following complaints. And secondly, I noted the complaint around poor support to disabled patients, and the response was better training. But I wasn't sure if that necessarily means that there's a change of practice at a local level. So I just wanted to hear from you on both of those points.
Megan, you want to come back?
Sorry.
Yeah, go ahead.
Yeah, I think that it's important to see what's happening. With the second part of your question, I suppose you're right. It's not a change to practice. It's a refresher on what should be being done already. It's quite important the complaints feed into my side of the team, the engagement side, so we're able to see the complaints that are coming in, and it highlights areas that practice can be improved. So we'll definitely take it forward with the in terms of the patient with disabilities. It possibly isn't a change in practice, more of a refresher. So we can definitely feed that into our work that we do on engagement. I'm sorry, I can't remember the first part of your question.
Yeah, Richard. So as part of my role is I sign every single complaint off for the trust. So whilst they are compiled quite rightly by the care groups and have some of that immediate action, so sometimes they're twofold. Sometimes, as you say, it's attitudes and behaviours, which it was in this case. Sometimes it's education, practicalities, and then the care groups link in with the teams such as learning disabilities, or if it's communication, we use some of our CHAMPS meeting. We've also got Jane Michelle on the line, who's a clinician by background as well. So she'll work closely with the care group HIPS, HONS and senior management to make sure we've taken the right actions. Part of signing off the complaints, and everyone in that area will know, I'll often say we need to go back in 3 months and just check, or if we're seeing that trend still come through, then we go back and say, right, what action have we taken? What action do we still need to do because we haven't answered the exam question? So we do that sort of check and challenge. In the care group themselves, what they do is they use their safety huddles, their briefings to say, we've had this concern. Sometimes they use anonymized stories, but that's a way of check and challenging themselves if the actions they've taken has resolved the root cause of the problem, and most importantly, they've learned from that, so we don't have it happening again. And that's some of the conversation that we have in the patient experience group, that we learned from something over there to make sure it doesn't happen in another part.
Thank you.
Thank you very much, Kim, and thank you for your question, Richard. Ella.
Thank you. Thank you for the presentation. It was really helpful to see some of the, you said we did, sorry. My question was really around to what extent are we able to, and how often can we give feedback at a very personal level where appropriate? So if we know, because I think a lot of the examples you gave there were the actions we then took were kind of at a team level, or perhaps even higher, a trust level. And I think it's really important that in a learning culture such as we are embedding here, people do receive feedback when it's appropriate and when it's possible. So if it was something one individual or a specific team did, that the feedback is as specific as possible. We know that from a QI culture, feedback being as specific and clear as possible is really important for learning. I just want
to go first, Megan. Yeah. So Ella, where it's very, very specific and often individuals are named, we go back through and we have a conversation with the individual, especially when we can see its attitudes, behaviours, as one such was, do they need retraining? Are they in the right job? So we go back as close as we can to source and make sure that that individual is getting the support, because you're absolutely right. Where it's very specific, what we try and encourage is local resolution meetings, and the patient experience group, both Megan and Jane are very involved in those. So we bring back the care group with specific staff who could have been leading on the care, were involved in the care, and can answer those specific questions, such as, why did you do X when I thought you were going to do Y? And having the patient and support in the room, it's usually a relative patient experience team, they get an opportunity to absolutely talk on a person-to-person basis, because nothing is more important than that. The formal complaint is almost that last resort for us. We try and do, whilst you're in the ward, speak to the clinical matron. We advertise that on the care board, speak to your ward manager. If you're feeling, sometimes people feel slightly, if I complain, what's going to happen to me? So we've got Care Opinion Live, which is really, really powerful, that the team pick it up almost straight away and can still resolve it. Local resolution meeting, and all else fails, formal complaint. So we've got quite a few mechanisms in there that we can go back and absolutely support individuals, share learning, and most importantly, try and prevent some themes happening again.
Thank you very much. Alison, you put your hand down again. Did you decide not to speak, or did you want to come in?
I think Kim covered most of my points, to be fair.
Perfect.
Just expanding on the point around learning culture, but also a just culture. And I think the points that Kim has made, and, Megan, thank you for those very clear figures as well, because I think it's really important, as Kim says, to resolve complaints as soon as possible, and that they don't then get more complex and compounded. So thank you for all your hard work.
Thank you, Alison. Rob.
I just want to emphasise to members of the public listening in that it's really important to us to have this feedback so that our team get the compliments as well as the concerns, and that helps us have that really balanced view of what's happening across the organisation. I hope that members of the public watching can see that we embrace it as that learning opportunity, because that we said we did, and you can see through those examples that changes are made. So it's just to emphasise it's really valuable to us to see that. And thank you, Megan and team, for the work that you do and how you share it across our teams.
Thanks, Rob. That's a really important point, and it's well made, because many of us around the table and members of the public will know that it can feel very hard to make a complaint when you're a patient. It can feel vulnerable. And I think your point is such a helpful one, because actually we really want to hear feedback of any type, because we can learn from it. And I certainly understand how it feels to think, oh gosh, I hope it's all right to say this. But if you can believe, and we do, that we need to know so we can put it right. So that's point well made. Thank you. Kim, you're going to come in.
Yeah, I think it goes right back to the beginning, doesn't it? We're absolutely committed to recruit to values. We can treat, you know, we talk about, have you followed a policy? Have you followed a protocol? You can have all of the education and training, and you can be competent, confident, but if you don't apply your values and really truly listen, actually it comes across as incompetency, doesn't it, or not caring. So it's getting that triangulation. As yes, we can teach many policies, pathways we can go down, but without behaving with values and integrity, and that's part of our culture, that feeds into the learning and just culture, doesn't it? And it goes right back. And that's why we absolutely seek, if anyone is having a poor experience, please speak up so we can rectify it. And those of you know me well, yes, feedback is a gift. It might not always be what you want to hear, but if we don't hear it and people don't say it, then we can't fix it. So we do everything we can to give that safe culture and environment for people to not just our staff, most importantly our patients and their loved ones, to be able to speak out. And that's a really important part of our Aspire accreditation program, is do patients and staff feel that they're in a safe environment, because that's really key, critical, and how we triangulate that is really important.
Thank you, Kim. And Kelvin, I wonder if you'd make your point that you've put in the chat, because members of the public won't be able to see that.
Sure. So as a build on Rob's point, really, that compliments are actually often an opportunity to improve as well, because very often they're referring to some good practice, which if we adopt everywhere, we actually improve our service as a whole.
So, thank you. Thank you very much. Would anybody like to mention any more? I don't think so. Kim, if we could offer to both teams our real thanks for the work that you do. As I said at the beginning, it is difficult work, and yet it's so important. I mean, I'm old enough to remember that British Airways thing about it. They got better publicity from if you lost your luggage than if you didn't lose it, because of the way they responded to mistakes made. And I think the way we respond to mistakes made or inadvertent unkindness is really important. And I think it does make people feel a great deal better. Kim, would you like the last word?
Please, and I absolutely echo that. Thanks. Megan and Jane and the teams do an incredible job, and especially when people are so anxious or upset and nervous, and they often go above and beyond in making sure that the care groups are supported, and that face-to-face wherever possible happens in often very, very upsetting conditions. So I agree. Thank you, Mari. As you say, on behalf of the board, thank you all very much.
That's lovely. Thank you. And you're very welcome to stay, as this is a public meeting, but you probably have better things to do. But I'm very grateful to being here, both of you. Thank you very much for that really helpful board story, because it is always our intention to do things well, isn't it? And yet things will go wrong, and we need to make it easy for people to tell us when they do. So we're asked to note that item. The next is my report, which you have in the pack, quite a number of things in there. But again, I do really want to start with saying thank you to our teams for what they're doing. I had the absolute joy this morning, Robin, of walking across here when there were only 2 ambulances outside. And that is absolute evidence of the hard work that you and your teams put in. And I know how difficult that is. It's, I think I say this every time, but I feel it every time. It seems inadequate just to say thank you, because we are struggling against inordinate pressures, the like of which we've really never seen. And all of the work that's being done, not just to get movement through the front door and help people get home quickly, but also the work that you will see in today's pack going on around ensuring that our elective work is as great as possible and those lists are gone through as quickly as possible. I was in a wonderful meeting this week sometime where we were talking about elective care and emergency care. And it's not an acronym, but people don't know what it means. And so it's, I always remember it as care that you're planning to have, or emergency as care that you didn't plan to have. But it's just interesting that we use language that isn't always understood, don't we? And pathways, people think pathways are ways you get to your front door. So just always worth remembering when we're with other people. So my thanks for that. I think something I'd like to draw out of my report, two things really. One is the ongoing work that we are doing with our system colleagues, our whole integrated health and care system. And I honestly think that work is building up and is increasing and improving the way we work with people across our communities. Members of our public don't know that we're different organisations, and I think all the work that we're all doing to make that joined up approach to how we respond to citizens is very important. So that's something that Steve and I, but also other board colleagues spend a long time doing. And the other thing I'd like to comment on is the baby loss service that Steve and I were privileged to go to this last month. It's always a very painful service to go to, and yet it's incredibly well attended. And I think I've said before, I often talk to people who actually lost a baby 50 years ago, people in their 70s and 80s who weren't allowed to grieve in the way we are able to do now, and they attend. And I think one of the other lovely things about that service is how many children attend. So it's whole families who come, and I have been told so many times how helpful that is. So I'd like to thank the teams, the chaplaincy and the midwife teams who organise that service every year. And other than that, perhaps I'm very happy to answer questions, of which there may not be any on my report. In that case, then, having welcomed new people joining us, I would just like to note and recognise Alistair Grant, our former Chief Medical Officer, who retired at the end of October. Alistair has been a colleague for a number of years now, and we've really valued his care and his input, and in particular, the way he attended to our values, Kim, as you've just mentioned, how he did care very much and lead the whole piece around behaviour and doing things well. So our very best wishes to Alistair. And then finally, I want to thank you, Adam, for the work that you have done with the Freedom to Speak Up role. Very, very important role. And we've got a paper in this pack. We always have a non-exec champion for the Freedom to Speak Up role. And I really have valued also, Aled, your input. And I know, Richard Cramer, would you like to mention how you're going to be taking this forward? Because Richard's going to become our new guardian.
Yeah, very happy to do so. Yes, I'll be linking in with Joe. I've, as Kim knows, it's been Freedom to Speak Up month, so I've attended event to mark that month, and also with the champions. And I could really see that we are not just leading the way in this trust, but regionally as well, which is really powerful to see. And finally, Aled has a lot of national expertise around this. And so whilst I'll continue to meet with Joe regularly, Aled has kindly agreed to come in ever so often just to give us that national input as well, which would be really, really helpful.
Super, thank you. Thank you very much indeed. So if there are not any questions, please could we receive and note my report? Could we also note the appointment of Richard Cramer as our new Freedom to Speak Up champion? And also, Matt Hill has kindly agreed to be our maternity safety champion and the chair of our organ donation committee. And so I'd be grateful if people would approve Matt as a member of the Quality Assurance Committee in order to link up those two roles with our Quality Committee. So thank you for that, Matt. We're really grateful for you doing that. And that brings us to item 7, our Chief Executive's report. Steve, please.
Yeah, thank you, Mary. I'd like to update on 5 areas within the report and also give a brief summary of the budget, which was confirmed last month, and provide an update around that. So the first item I'd like to update on is set out in section 4 of the Chief Executive's report, the use of temporary escalation spaces. board members will see that NHS England have issued new guidance around the use of temporary escalation spaces, particularly with regard to ensuring that they are safe and provide good quality care. As board members are aware, we do use temporary escalation spaces in this organisation, in emergency department and in ward areas. Unfortunately, due to the operational pressures that were already cited on, those temporary escalation spaces have been used very regularly, consistently throughout the course of this year. It is helpful to have that guidance from NHS England setting out the checks and oversights that NHS trusts must have in place to oversee them. So I want to draw that to board members' attention particularly, but also you'll see later in the report, Section 9 sets out a number of the additional actions that we're taking within RCHT and in partnership with Cornwall Partnerships NHS Foundation Trust. Those actions are designed to improve flow and to reduce the level of exceptional pressure that our organisation is experiencing, including an anticipation that the impact of those actions, plus other actions that are already underway, will be our key way to enable to start to step out those temporary escalation spaces. So we are determined to do that. So I just wanted to identify that. In addition to that guidance, we're doing everything we can as an organisation, and our partners are similarly working to enable us to reduce that level of escalation. I'll say a little bit more about that in a moment or two. Second update is about the CQC inspection. So Section 10 of the report, you'll see identified that we were notified by Care Quality Commission of a regular routine inspection of radiotherapy, nuclear medicine and radiology services. That inspection took place yesterday. We welcomed our CQC inspection team yesterday morning, and they spent all of yesterday undertaking that inspection. As is the way of these things, we don't receive any formal information until the publication of the CQC report. And currently what we're experiencing is a number of months between CQC inspections and the subsequent reports being provided. Whilst CQC were on site, they did not identify any immediate safety issues or issues of concern. So nothing that was identified for immediate rectification. And as soon as the CQC report is finalised and published, then we'll bring that to board's attention. Then to draw board members' attention to Section 9, which sets out some of those additional actions which are being undertaken in partnership between Royal Cornwall Hospitals NHS Trust and Cornwall Partnerships NHS Foundation Trust. So I just wanted to give board a latest update on the progress of those actions. The first stage of the cardiology virtual ward will be commencing in mid-November, and then progressively increasing its capability and capacity during December and into early January. The third community frailty same-day emergency care unit opened ahead of plan. That third unit was at Camborne Redruth Community Hospital. So our system now has 3 community frailty same-day emergency care units operating, one at Bodmin, one at Camborne Redruth, and one at West Cornwall Hospital, and we expect all 3 of those frailty same-day emergency care units to move to a single operating model during December, so we can consistently ensure that South Western Ambulance Service and GP and wider primary care have a consistent level of service and access into that frailty service. And that's really designed, as we discussed previously, to enable appropriate patients to receive their care in the community rather than coming to the emergency department, so they can receive more timely care and to reduce some of the level of pressure experienced in our emergency department. The single point of access is now operational. That will expand its hours in early December, but it was operational ahead of plan, and that provides a single point of access and coordination into services outside of the acute hospital to streamline how primary care and South Western Ambulance Service access those community-based services. And the care of the elderly, the end-of-life virtual ward, we're anticipating will be implemented next month. So on track, progressing rapidly with those set of actions that the 2 trust boards agreed and discussed at our recent joint board seminar. In addition to those areas, there is a significant set of other actions underway. That's been the focus of previous board discussions. Those things continue, and the collective impact of those actions the action is already underway, and further system actions are designed to enable us to start to reduce those escalation steps, and for that to enable an improvement in ambulance handover time, ambulance response time, and ED performance time. Also wanted to briefly update on the St Austell Elective Surgical Hub. That is a fantastic new facility, opened on the 7th of October with first patients receiving their care then. That initially commenced with local anaesthetic, low complexity procedures, and then subsequently increased to full general anaesthetic surgery. So really huge amount of work from the team involved in enabling that. We did last week implement a temporary pause in services to address some equipment provision aspects, and that temporary pause is now concluded with operations recommencing at St Austell Elective Surgical Hub this week. And I'd just like to acknowledge an extraordinary amount of work from our colleagues involved in mobilising what is a fantastic facility, and also acknowledge the partnership working with Cornwall Partnerships NHS Foundation Trust to enable that to commence operations to plan. Just briefly, our financial recovery plan is progressing. We've seen significant improvements in the level of cost improvement and efficiency delivered, and significant improvements in the level of recurrency in those cost improvements. And we're expecting to be marginally ahead of our year-to-date plan for total cost improvement delivery in month 7. So a really significant effort across our trust to address that. As part of that, we've seen reductions in agency cost expenditure moving towards plan, but that's an area where we have further work to do to enable that to progress further. One of our key risks to the financial recovery plan is the number of patients with no criteria to reside in our hospitals, and that would currently be operating at somewhere between 18 and 20% of our hospital beds being occupied by patients with no criteria to reside. That level and the escalation of additional capacity associated with that is certainly a significant risk to us. But the actions that I referred to earlier include a set of actions designed to address that and enable those numbers to reduce. So they were the updates on the content of the paper already provided. Just briefly in terms of the budget, and we'll provide further detailed information at our next board and public. Colleagues will have seen, I'm sure, the headlines of the budget announcements. An additional 22.6 billion allocated to Department of Health and Social Care spending for the 25-26 financial year compared to 23-24. Effectively, that's about a 4% increase on average over this current year and next year. A significant proportion of that 4% increase, it is assumed, will be used to fund the pay review body recommendations for the pay awards for NHS staff in this year, as well as the separate pay settlements for consultants, doctors, and associate specialists. And in addition to that, there have already been significant pre-commitments identified against the increase in resources, including additional elective activity. So we haven't yet had the implications of that budget allocation provided through to system level or to provider level, and that's the detail that will provide an update to board members as and when that is provided. The budget includes significant updates around capital development, including an expansion in capital resources to the Department of Health and Social Care and to the NHS. It includes, for example, a confirmation of £1.5 billion for additional surgical elective hubs and diagnostic hubs nationally. It also provides an update on the new hospital programme. And the update there is a confirmation of continued investment in the new hospital programme. However, the 7 hospitals most at risk regarding RAC will be prioritised. Further detail will come in due course. We're expecting that further detail to be next year. So with regard to our Women and Children's Hospital, we don't yet have any clarity on the timeline for funding to be released for the Women and Children's Hospital. So that is an area that we're watching very, very closely and working closely with the new hospital programme team. to provide whatever information is necessary to enable that to progress. And of course, that's a critically important scheme for us and for the wider health and care system. Two other things to identify or flag with regards to the budget. The first one is an expectation around improved productivity. So the budget sets out a government-wide productivity target of 2% as a minimum productivity improvement. So we'll, of course, need to be mindful of that. Just for board members' information, the latest nationally published productivity information shows that RCHT is currently just over 5% productivity improvement year to date over the last 12 months. So better than the 2% productivity improvement that's set out. So a positive reflection indication of the work that's underway. And also that latest information shows that our productivity position compared to the national 1920 baseline is now better than the South West regional average and just about in line with the national average, both of which are significant improvements on prior years. The other parts to briefly summarise is the impact on social care. So the budget includes £600 million in additional new grant funding for adults' social care, and includes an additional 86 million boost to the disabled facilities grant nationally, which is assessed as enabling an additional 7,800 more care home adaptations. Just for our context, Cornwall and the Isles of Scilly would generally be about a 1% allocation of a national indication. I'm not able to confirm that's how those funds will be allocated, but when we look at it from an NHS perspective, typically we'd expect in our system about a 1% allocation on any national basis. The budget also identifies a 3.2% real terms increase in local government spending power. We should be mindful of the potential implications of the national insurance employers' contribution, and there's been significant coverage from a social care provider perspective in the media recently about the additional financial pressure that's likely to bring on what is already a very financially pressured sector, so potentially implications from patient flow in the NHS arising from those matters. So hopefully that's a helpful brief summary of some of the budget headlines. Happy to take any questions on any of that or the other contents of the Chief Exec's report.
Thank you, Steve. As ever, a really, really informative and helpful report. And I think hats off to you for doing such a great summary of the budget implications for us. I've got a number of people want to speak. I'll start with you, Richard, as you're in your room, and I've seen you, but I've got 3 or 4 folks. So if we could be as succinct as possible, and perhaps we could take a couple of questions and then respond. So Richard, you first.
Being succinct, hopefully one will redistribute time, if not save time. I would have noted item 12, the board assurance report from Finance and Performance Committee, just to echo Steve's comments around the St Austell Surgical Hub. And one of the recommendations in that report, which seems appropriate to raise now, is that we ask the board, we would like the board to write to those teams, notwithstanding some of the difficulties that are still faced in the ramp up, but for the extraordinary amount of work across a number of teams to make that happen and to reach the go live date. So I'll just raise that now rather than under item 12. Thank you for the whole report. Thank you for that update on the budget. That's really helpful. My question is around the temporary escalation spaces guidance, just for assurance to the board at this moment. Do we have any sense of how well we meet those guidelines now as we're using temporary escalation space?
Yeah, great question. Thank you, Richard. I am going to take a couple of other questions, if you don't mind, and then come to you, Steve. So, Adrian, you're next.
Yeah, mine is in relation to the launch of the new framework training and communications around sexual misconduct. I was recently sent a policy as part of the consultation, which was around sexual safety, but it stated right at the beginning that that was only for patients. So my question is, whilst we're waiting for the rollout of the new framework, can we be assured that we have adequate safeguards in place for our staff?
Thank you, Adrian. And I'll take one more and then come to you, Steve. Alison.
Yeah, so I guess I wanted to comment from a celebration perspective, given the complexity of Steve's reports, and just draw out very quickly 4 points. One around the productivity and acknowledging all the hard work that clinical and operational staff are doing to make inroads to our productivity. The second point also on the St Austell Surgical Hub, to say thank you to the estates team and CFT, also to recognise that tremendous job that the care group has done. And in visiting the site, it is an amazing facility for patients. Third point is about Jo Baden-Fuller, our new Deputy Medical Director. I think it's a fantastic good news story to see somebody who's trained in Royal Cornwall and then come back to Royal Cornwall in her new Deputy Chief Medical role. And the fourth point, just want to say well done to my own team, Learning and Development, and a thank you to Truro and Penwith College in helping us to win the T-Level Regional Award at the Department of Education. Thank you.
Yeah, well said, Alison. Thank you for those. Steve, if you could pick up Adrian and Richard's questions.
Yeah, absolutely. And I might ask Kim to add to the first aspect, which was around temporary escalation spaces and are we compliant with the national guidelines and requirements. The brief answer from me would be yes, from an oversight perspective. However, the national framing of these spaces are that they are temporary, used in extremis and escalation. And as I mentioned right at the start, they have clearly been in use consistently over an extended period of time. So we must be absolutely clear on the extended use of them and continue to take every possible action to enable them to be stepped down. But I might just ask Kim, is there anything you want to add with regard to the national required oversight of temporary escalation spaces?
Thank you, Steve. So I'm really pleased they're calling them temporary escalation spaces, not corridor care. That's really important. We've always abided by that principle. So whilst we are compliant by guidance and principle, and there will be a second report. So we're already on our second quarter of reporting, going through part 2 of QUAC. The only part that we haven't been able to comply with is de-escalation. We've still been unable to de-escalate out of those, and we continue to work with our system partners in that regard. But that's probably not out of kilter nationally either. So that's what we're concentrating on as we move forward.
Thank you, Kim. And then the second question was around the sexual misconduct and safety, particularly with regards to staff. That has been a significant area of focus for us as an organisation to ensure that our staff are safe in every instance. Alison, do you want to provide any further information around safety for staff with regard to sexual misconduct?
Yes, so this is obviously an area that Kim and I work across in terms of HR, safeguarding, and to say there is some work that is coming to our next People and Culture Committee, which joins up both that patient and staff perspective. So Adrian, you'll see a lot more coming very shortly.
Sexual safety charter as well, haven't we?
Yes, and of course our signatory to the Sexual Safety Charter provides a clear framework in the actions that we take as a board and as an organisation.
Thank you very much. Richard Cramer.
And that was a brilliant presentation, Steve. You covered so much ground and with so much clarity. I just want to reiterate one of the points you made and ask a question, because from a system perspective, the NHS isn't going to thrive without more investment in social care. And we have 22 billion for the NHS and 600 million, spare change for social care. And I think there's some work to be done for the Chancellor to understand that social care providers provide a public service. You talked about that 18%, I think you said, of trust beds are occupied by people who don't need to be there. So I just wanted a bit more information, if possible, around how long, what are the trends, how long it takes people to be discharged, and what our response can be. Is it because the funded places aren't there, or is it more joined up working, better communication, better information, better discharge plans, better support of transport? It'd be just good to get a bit of a flavour of our response.
Thanks very much. Adam.
Thank you for the report, Steve. My question is on section 15, patient flow, which refers to the winter plan. And it's a two-part question, I guess. It's just some assurance around engagement with the council and what's the council's role in terms of the winter plan, because it's not mentioned, and what is mentioned there in terms of the actions that are being taken forward. How are we going to track their performance, please?
Thank you very much. And if I just take Aled and then come to the
Mostly
answers.
been covered. Thank you by Richard's points on the temporary escalation spaces. But I was really pleased to hear about the risks of unintended normalising of that space. It's in the guidance that we shouldn't be doing that, so it's really good. And also it's good to see this as a system issue, that we've got to get a flow. It's sort of connected, and there's a strategy to deal with that. I do wonder if we could track the implementation of the principles through quality committee, in terms of, it's always great to have principles, it's much better to see the implementation of them, and how possibly we could look at that in terms of those particular spaces. But yeah, thank you. A great report. Thank you very much.
Thank you very much, Steve. That's 3 areas there, and then perhaps we could wrap up.
Yeah, and all interrelated to some extent. I might ask Robin to comment in a moment. In terms of the no criteria to reside patients, it would be for all of the reasons that were mentioned and others as well. So the work that we're undertaking internally and with Cornwall Partnerships, NHS Foundation Trust, and across our wider system is designed to address all aspects of patients with no criteria to reside. Just to give us some context, the position yesterday, I think, was 106 patients with no criteria to reside in Royal Cornwall Hospital's beds, broadly split. About a third of those would be considered to be P1 patients, by which I mean patients waiting to go home with some form of onward community care. About a third would be patients waiting for long-term residential care, and the remaining patients would be waiting for some form of reablement care. So that would be the operational kind of mix that we were experiencing yesterday, which wouldn't be untypical. We have seen that number be at 120 plus at points over the past week or two, and we've seen higher figures than that as well. So that's the context. In terms of reporting, assurance and oversight, we are moving towards one single plan encompassing the totality of the actions that are underway, and for that to form the basis on which we would report and give assurance to NHS England through our tiering arrangements. As board members are aware, because of our ambulance handover performance particularly, we're in the highest tier of NHS England oversight and escalation, tier 1 for urgent and emergency care. But that same reporting would easily be replicable to report through Quality Assurance Committee, through Finance and Performance Committee to the board and to the ICB as well. So I think we'll be able to provide that clarity on the progress of individual actions and their expected impact on our overarching performance. But perhaps, Robin, if I could ask you to say something around that, particularly mindful of the work we're doing with Kingsgate colleagues on our actions at the moment.
Thank you, Steve. So we, our ICB colleagues are supporting us with an organisation called Kingsgate, working alongside us to help review our plan for our flow improvements and to make sure that we can reset exactly the direction of travel that we're moving in, and wrap around the support for the changes that we need to make, particularly in regards to what we call our medical model. And what we mean by that is the way that we function through the hospital, the time of day that we have our resources, and the way that we make the decisions and use the capacity that we do have to make that achievable, the first step we're undertaking as a whole system is we're planning we haven't yet set the language, so excuse the way I'm going to describe this, but a discharge event aiming for the main bulk of the discharges across RCHT and Cornwall Hospitals and Cornwall Foundation Trust, the main event to be across the week of the 25th of November. We've commenced work as a whole system towards that already, taking on board learning from colleagues that have been from both the Integrated Care Board and Cornwall Foundation Trust, being on site, visiting our wards, picking up learning and opportunities to, in some regards, use different pathways rather than the pathways that patients are currently on and delayed on, and understanding if there are alternative solutions to get those patients discharged. And actually, it's really encouraging that we're all coming together as one whole team. And for that main event week, we are going to have a command centre created so that we can really have that rapid turn through of patients, and to demonstrate the join up across social service, social care and health. That command centre will be in New County Hall, which, for those who don't know our geography, is the council offices. And that shows their commitment alongside us to be joined up as one whole team to make best use of the resources we do have. And our intention is to use the build up to that week and the week itself to not only be about the patients that are on the pathways commonly known as delays, but also the pathways. And I know Mary told us about the pathways meaning the route to your gate, but the exit route for patients also we call pathway zero. So that's the patients that go home with no further support. So we're trying to all work together as one team to accelerate the way that we safely discharge patients, challenging ourselves. Can we bring up our pathway zeros to the straight home patients? Can we get more of those home in the morning? Can we bring every discharge forward by 1 hour? And that sounds small, but when we have 150 discharges a day, bringing each one of those forward by 1 hour is actually really significant when you look at a crowded emergency department. So we're trying to be realistic in that, and we're working together as one team and learning from each other and joining up our approach. So our intention, linking that to the winter comment from Adam, is that I call it gets us match fit. But what I mean by that is actually there's some learning to change the way we work if we really embrace the work between now and the 25th of November, and then the week of the 25th of November, and then there's there's how we move that into a sustainable place. And that then starts to link up with some work that Ella's leading on in the overarching, more strategic way of changing the way our delivery works across the whole system. So it does start to tie together. We had a long debate in Quality Assurance Committee and Finance Performance Committee regarding winter, risks for winter, particularly talking about our patients that are currently on this pathway 1 to 3, and that being significantly above trajectory. And this is our system response to us being above trajectory to come back to trajectory to give us that space to be ready for winter. And my final point I'll make is we are using language around how do we build the buffer into the way we're operating. So we know, and everywhere struggles, not just in Cornwall, with discharges over the weekend. So our language in our planning sessions is, well, how do we maximise our opportunity Monday to Friday so we have the buffer for the weekend? That same language is, how do we maximise our opportunity this side of winter really kicking in so we have the buffer? We are really talking it. We mentioned with Kim earlier with the escalation spaces. We're using this as our opportunity to, with the intention of reducing the pressure in the whole hospital. So that should be less crowding in ED, should see us coming out those temporary escalation spaces as well. That's how it's joining together. And Steve's report outlines further in more detail some of the other actions, which I won't repeat.
Thank you. I did briefly mention the intention to bring that full set of actions into a single oversight plan, which would, from a monitoring perspective, would then enable that to be reported to our committees, to the board, and given its impact and its relevance to NHS England and to our ICB and wider system colleagues as well. So we have real transparency on the progress and the impact of those actions that are underway.
That's really helpful. Thank you, Steve. I think probably that has exhausted the questions, unless, is that your hand up as well? It is. Sorry, didn't see it on the screen. Go ahead.
No, sorry, Mary, sorry. It was just based on what Steve has just said. And I think what we're seeing more and more, which is really encouraging, is the triangulation of information across our committees. So, you know, the fact that these ideas, these actions will come back for assurance to Quality Committee, Finance and Performance Committee, and I suspect also to our People and Culture Committee, where there are workforce implications. But it's really important that as committees doing the work on behalf of the board, that we're able to be cited across the piece on the actions, so that we can interrogate and ensure that we're happy with the way things are going.
Yeah, good point, Isabel. Thank you. Thank you very much. So, Steve, with great thanks for a very, very good and helpful report, could I invite the board to receive and note it? To receive and note the progress on the governance improvement plans, and to receive and note the shared priorities for winter. If people could indicate in the chat, please, that would be really helpful. Bringing us to item 8, our quarterly strategy implementation report. And Ella, would you be kind enough to introduce the item? Thank you.
Thank you, Mary. So this is our quarterly strategy report, and it tracks our progress against our 10-year strategy. I'll try and be brief, knowing that we've got such a busy agenda today, and then take questions. There are many elements in here that I think we're still really, really proud of. I do have to flag that this is a month where a quarter where we've seen a bit of a step change with regards to the number of milestones that are now being RAG rated as amber, unfortunately. And some of those are items on our agenda for later today, such as our e-care programme. We've already spoken around the fact that Women's and Children's programme is under a temporary pause whilst being reviewed nationally. Our university hospital status and green plan, whilst we are making some progress on both of those, they're areas where we are having to think really carefully around how do we resource properly those ambitions that we have in those areas. So hopefully the report provides sufficient detail with regards to those and an understanding of why we've RAG rated those the way we have, and for assurance at board, those have been discussed at our committees as well, with a particular relevant kind of update for each of our committees. I just wanted to also highlight the case study in here, which I think is a really fantastic good news story. So Royal Cornwall Hospitals hosted the first ever health tech symposium. It's the first of its kind, really brought together lots of experts from both the industry and from healthcare to discuss the art of the possible in terms of the technology that's in many cases already available to us, and we could really optimise for better patient care, and in some cases really imagining what the future may look like. So that was really, really exciting and has already sparked some conversations around what we can change here and now in the way we do things. So I think really emphasising the importance that we do find space and time to do those forward-looking things amongst our very, very busy agendas and highly challenging areas. Also, just to highlight for Trust Board, we have made a recommendation and we're asking Board to approve today that we move to biannual reporting for this report. And that was a request from all of the committees, in fact, around feeling that the frequency probably would be sufficient to be bi-monthly on this one, enabling us to do more depth when we do it, but at a less frequent interlude throughout the year. I'll stop there and take questions.
Great. Thank you very much indeed. Thank you for the report. Colleagues, are there questions for Ella? Richard.
Really good report, and as noted, we've had a good airing throughout the subcommittees of the board. I think the overriding thing for me as I've sat through the different discussions in those committees is, are our ambitions in the right place? This is the first, I think, one of the few reports that is telling us that there are some constraints, some of which are absolutely external and therefore are holding us in place. Others may be internal as we grapple with the day-to-day challenges that are facing the NHS and this system in particular. And I just wonder, not for now, but perhaps there is a moment for the board to pause and just consider the extent of our ambition to help those delivering it really have clarity on the pace at which we expect all of these things to be achieved.
Thank you, Richard. Ella, I'm going to take a couple of other points then come back to you. But it's a point well made, Richard. Thank you for that. Alison.
Yes, I just wanted to pick up on Ella's point about the move to biannual reporting. I think that would be really helpful, particularly when we are talking about strategy. I did note today we've got some inconsistencies in the board pack on, particularly in relation to how we're talking about our OD programme. And that's because obviously things are moving all the time. And just to comment on that, really for colleagues' benefit, the OD programme is receiving absolutely excellent feedback. It's a small team delivering, and I really would encourage colleagues, I know there are operational pressures to attend those sessions, because it does make such a difference in terms of embedding values, embedding behaviours, and talking about the things that matter right now in terms of those operational pressures. Thank you.
Oh, thank you, Alison. You picked up a point that I was going to make under a later paper, so perhaps I'll raise it under the later paper, but thank you for that. And Robin.
Question, it links with Richard's point. The Technology Symposium really created a positive buzz in our organisation, and members of Ella's strategic team are linked up with the operational team from. We are only a one strategy organisation, but we strategically, what does our elective recovery over the next 5 to 10 years look like? How does that join up to the technology opportunities that were being discussed and described in that session? So really trying to bring our thinking into the space of, actually in 5 years' time, how would our elective offering, patients who come for planned procedures, how would that offering look, embracing that technology opportunity that exists? So just to show that we are tying that together into our everyday way of working, and the opportunity to thank Ella's team for integrating with us in how we start to take forward that challenge.
Thanks, Robin. And Ella, if you wanted to come back on any of that.
Well, I think Richard's point around it is really important that we continuously take stock in terms of our ambitions in the right place, and I think really importantly, are we resourced to deliver those? We do need to be realistic on that. I think my sense is our ambitions are in the right place. I think there are examples of where we need to really consider the pace and making sure we are not asking people to do too much at once. We're not confusing people in the way we're presenting that, and we have real clarity on our strategic priorities. So I think it's food for thought for my team around how do we this year in the planning cycle ensure that strategic ambitions and milestones are accounted for as much in the operating plan as some of the more immediate pressures are that we discussed. And perhaps at board we also need to be bringing that challenge and bearing in mind those.
Right, thank you. Ian. You're on mute, Ian. I'll take Adam and I'll come back to you, okay? Adam.
Thank you. It's a really helpful paper. I really like the idea of going twice yearly, and a request that if we are going twice yearly, can we use one of those sessions to look at a more medium-term view and how are we doing against 2032? Because understandably we're focused on the current year in this, but it feels helpful, building on what Richard and Robin said, that we take a medium-term view as well in one of those sessions.
Really helpful point, Adam. Thank you. Steve.
Really good report and useful challenge in terms of the prioritisation and the timeline. Just going to suggest, Ella, we've got the Darcy review outcome already. We know that I think early next year we're expecting the 10-year NHS plan. That's out to consultation and engagement now. and by the spring of next year, we will have concluded the commissioning intentions for the new year. So that feels like three key sets of information, which might be then very timely to then review and take stock on the ambitions each year going forward to test, does the new 10-year NHS plan support and align them? Do the commissioning intentions align? Which might then allow us to address kind of Richard's challenge and also give us an opportunity to refresh and update that plan.
Yeah, thank you. Yeah, that's helpful. Ian, are you back, do you think? No, you're not. You still haven't got any sound.
No.
Yeah.
Yes.
Yes.
Excellent. Apologies for that. So, yeah, agree with a lot of what's being said. I was just going to make the point in terms of that biannual report. I think it'd be really good to think about the timing of that with the MTFP updates that we bring biannually to Trust Board as well. Apologies if that was covered. I tried to reset. So, but yeah, we can pick up that in terms of making sure we've got that alignment, because that's been something we've talked about in the past, that our financial strategy aligns with our overall strategy.
Yeah, really helpful, Ian. Thank you for that. Kelvin, last word.
Yes, thanks. Similar points really to Adam and Ian, that if we do move to a biannual report, I think its structure is going to need to be very different. At the moment, it's kind of a highlight report. It's similar to the other reporting that we do across our programmes. And obviously, if it's only twice a year, nothing in a highlight report, in a sense, is going to be current. So it's going to be much more about how we are actually progressing change on a much broader basis. I think we'll have to restructure it.
Yeah, but yes, and I think that links with points that Richard, you frequently make about where are we in that cycle of what we're doing and whether it's working and whether we need to change it, but without losing the ambition. So yeah, thank you very much. Are there any more comments, questions on that report? Okay, in which case, could we please approve the change in reporting frequency for the update to be biannual, but bearing in mind the comments that just been made about how we structure the report, note the achievements arising and really celebrate the conference that was held, and then note the delays in section 2.1, including the Green Plan, e-care, and the commencement of the Women's and Children's Hospital build and enabling works as a result of the national review of the new hospital programme. So perhaps if we could indicate in the chat. And I'm desperately trying to see if we can bring Sarah Coulter forward, but we might not be able to. And I don't think we can bring Joanne Burton forward, but I am keen to press on with the agenda. So I wonder, Isabel, if you could bear to give us your Quality Assurance Committee report. And we may have to dot backwards and forwards a little bit, but it seems an awful shame to lose time in a tight agenda. So sorry to throw that at you, Isabel. I'm wondering if you could give us your Quality Assurance Committee report.
Thank you very much. I'll try and keep this brief so that we still want to fit in a break. This section on quality, you'll see there's an awful lot of papers that are going to be coming through the board today around quality, and I think it indicates the importance and the focus that the organisation has on all things relating to patient quality and safety. So first of all, I probably just need to pay tribute to everybody who's involved in all the work that comes to the Quality Assurance Committee. For members of the public, just to point out that we actually have two committees that we report on back to board. One is our own Quality Assurance Committee for RCHT, and we also have a joint quality committee with our colleagues at Cornwall Community Foundation Trust, which is now meeting bi-monthly. So the report that I have here today for board reports on activities through our quality committee for September, October, and the September meeting of the joint quality committee. So you'll see in the report that we have the headlines around the items that are going to be coming to the board for approval including one which we've just covered, which was the quarterly strategy report. We'll also be receiving the annual complaints report, which ties in with the board story that we heard earlier. We were asked to also receive for assurance the seasonal plan, which Robin mentioned, and that I hope we did cover fully, actually, at our quality committee in terms of seeking assurance around our plans for winter, particularly. And I think also the other thing just to note is that we were able to close an action which I think came through on the board action log regarding the trends around the controlled drugs DATIX reporting. And so we received that again at committee last month, which gave us assurance that the trend that we had noted has now reversed. And Jill Derrick, who very kindly came to our meeting, gave us full assurance around that. So we were very happy to sign that off as complete. I won't go through all the content of the report. It's a lengthy 27 pages worth, covering all the various items. You'll see that there are some items there with partial assurance, but I do just want to flag up to board and escalate a couple of items which at the moment we only have limited assurance around. The first of those is really around the 7-day services assurance, which we received back in September, where we are not assured at the moment around the standards that we're expected to achieve around 7-day services, and in particular, one of the standards, standard 2, which is about the opportunity for seeing a consultant within 14 hours. The pressures would appear, unsurprisingly perhaps, to reside within our ED and with our medical specialties. So what we've asked is for a review of our plans to achieve those standards, and for that to be received within 3 months back at our Quality Assurance Committee, to allow the time necessary for that work to be undertaken in detail. And I'm sure that Mary will be picking that baton up from Alistair's work up to date. So I welcome the opportunity to chat with Mary about that at some point in the next few weeks. So that's the first item that we just want the board to be aware of. And the second, again, is of real concern, and it's about the capture and management of harm action plan, which was flagged back in September. We requested an updated report on this for October, but sadly that's had to be deferred again to come back to us in our December meeting. So we're not particularly happy about that delay, but we do appreciate that there's further work that needs to be done to ensure that that report is robust enough and tackles some of the delays that have been flagged up, so that we can take full assurance from what comes back to us in committee in December. So those are the two items that the board needs to be aware are, we are seeing as limited assurance at the moment, and they're both really critical areas, particularly in the management and capture of harm, I would suggest, because that is, in theory, one of the core functions of our committee, to make sure that we are actually minimising potential risk of harm to our patients. So those are two very important areas. And I think finally, just to say that our joint meeting with our colleagues at Cornwall Partnership Trust are progressing really well. We see regular items coming through which Kim steers us along with, particularly around safeguarding, around falls and around pressure ulcers. And we're looking at those in an integrated way across the two providers to make sure that we're actually able then to engage in conversations with our wider system colleagues, because of course a lot of the actions that need to be taken go beyond the borders of our organisations. So there's very important work taking place there. And I suspect that agenda will continue to expand as we become more and more involved in integrated work with our system. So I think at that point I will stop. The report is pretty full, and hopefully people have had the opportunity to read it, but I'm happy to answer any questions that you may have, or I'm sure Kim will help me.
That's great. Thank you. Thank you very much. It is a long report, but it does just demonstrate the amount of work done by your committee and other committees. And I think for the purposes of members of the public, a lot of the what we would call heavy lifting of the board's work is done by our committees and is reflected in these chairs' reports. Isabel, I have a question, but I just wonder if anybody else has anything to raise with Isabel on this chair's report. Mary.
I just wanted to reassure Isabel that both the 7-day services and the harm review issues that you've raised are firmly on my radar already, and absolutely we'll get together soon to discuss a way forward for both of those.
Thank you, Mary. That's great. Look forward to it.
Anybody else? Ella.
Yeah, it wasn't really a question, but just a bit of further detail. So fractured neck of femur is mentioned in the report as an area where we are still not where we need to be. And we know there's associated risk there around mortality. This has come up at Care Group Performance Review this week. And we have an ongoing quality improvement project with fractured neck of femur that has made some improvements on some of the metrics. But what we've agreed this week is a refocus of that project. And now with Mary in post, getting her and Joe's perspectives on that as well, to ensure we can make the most of the opportunity that will come from our reset week at the end of November and the improvements in flow and what that will mean for our ability to get our patients to theatre in time and into the right place for the right care. So just, I think, linking as well to what Robin was saying, the impact on flow is clearly a quality matter, but it will have knock-on effects on other quality metrics within the organisation if we get it right.
Thank you for that. And I think what came up at the last board meeting was including in that review how we manage pain in those patients, and that, you know, that they may be patients less likely to express their need for pain relief. And I think that was going to be part of that inclusion. So thank you for that. Isabel, I just wanted to celebrate the, on page 16, the average length of stay being the lowest for 2 years. And I think we should pause and say well done to people for that, because we all know it is not great to stay in hospital when you don't need to. So that's lovely. And perhaps I won't, I had a little amusing thing, but I think perhaps I won't take the time to say it. So are colleagues happy that we pause after Isabel's report? We take our break now for 15, how long is it, Lindsay?
Murray.
Oh yeah, I didn't see you, Kim. Go ahead.
Thank you. Ella, it's really important what you just said. So Alistair at the last Quality Assurance Committee had committed to bring a deep dive. That has been requested before. We believe there was going to be a perfect week, and that full report is due back at this month, the next quack. So if that isn't going to be possible, if you could just let us know, we'll have a conversation. Otherwise, that you're right, that full report, including management of pain, is due back at the next committee.
Is that going to be okay?
I'll have to check that with the team and come back to Kim directly, but that's, yeah, thank you.
Thank you, Kim. Sorry I didn't see you there. And then Isabel.
Yeah, no, I don't want to prolong the conversation about fractured neck of femur, but just to give some assurance that we are really scrutinising this and have been doing for several months. It's really disappointing to see where we are with this, but I do think that the actions that the organisation's taking to try to reduce both prevention, so that ties in with all the integrated falls work that we're doing, and in particular thinking about our links with care homes. So we're doing a lot of work trying to understand the reasons for falls, the prevention around falls, and whether that actually helps us in terms of a reduction in fracture neck of femur. But of course, all the pressure still remains on the metrics that Ella's alluded to. So we will be continuing to monitor that very, very closely.
Thank you. Thank you very much. So then we are asked to note the report and also note the escalation of the assurance on the 7-day services. And we've heard Mary's response to that, and also on the harm review. And again, we've heard that. And I'm concerned that when we have things escalated to board, we also pin down where they're going back to and how, as a board, we're going to be assured that they have been resolved. So I know Lindsay's got a method in hand for doing that. So thank you very much. If you could note that report, we will take a break now for 15 minutes and be sure we can start again at 10:40. Thank you.
My name's Megan and I have been a clinical practice educator for general surgery for 2 years now. With all of our new starters, I make sure that me and my little team, we meet with each new starter individually when they first start within the trust. I think that's really important. From the get-go, we try to promote them talking to the Freedom to Speak Up team. In our room here, we've got the Freedom to Speak Up poster behind me.
I think we have to have understanding that people come from various cultures and traditions, and I think it's important that we break that barrier of misunderstanding. And you know what, this is how people work, and it's okay if you are not being understood all the time, and there's a lot of misunderstandings, but because somebody spoke up about it and shared their experience, everything became okay, and moving forward we can actually learn from one another, and that's really important.
So in the care group we have a new starters day that happens once a month. So it's a little bit different to trust induction, but emphasises what is covered in trust induction, and as part of that we talk about freedom to speak up and make sure that people know that there are freedom to speak up champions that they can go to if they have any issues that they're worried about.
Speaking up means being listened to and improving the environment for my colleagues, the patients, and hopefully in future making a better, more functional hospital.
So I think it's important that we create an environment that people feel safe in, where they can trust members of staff and they know who to go to and who to talk to if they're struggling.
So I think for me the really important part of the champion role is to make it accessible to everyone and to make everyone feel like they can access it. I just feel like it's so important that we just speak about it as loudly as possible.
Who are the people available for speaking up to?
So when we send out the messaging across it, we always send the Freedom to Speak Up poster, which we all love. But obviously it's almost like that is the last resort. We should be thinking about our team leaders, our managers, all SMTs should be accessible within your care groups, and then it's really Freedom to Speak Up should be that second last resort.
My name's Chris, I'm the People Engagement Lead at RCHT, and what sits within that is a staff voice essentially, which is around our surveys, making sure our staff voices are represented across the organisation and we're able to use that. What we're looking at in the staff survey, where those questions sit, are within the we each have a voice that counts section, and that's used as one of our key NHS People Promise areas to make sure that everyone has a voice and to make sure that we're listening as an organisation.
If you feel worried about speaking up within your team because you're unsure, please use one of the Freedom to Speak Up champions or even a colleague. But please, if it's on your mind, please express it. We're here to help and understand.
Everybody should feel safe to speak up openly or speak up confidentially. We will protect you, support you, and will take action on the issue you're speaking up about.
Yeah.
Right, welcome back, everybody. I think that was a really good break. Actually, we seem to have some nice chat. Those of us who are in the room. So thank you for building that in, Lindsay. And that was in response to some comments we received last time that we needed to have more frequent but shorter breaks. So I hope that's worked. But can you bear in mind you've only got 15 minutes to eat your sandwiches at lunchtime because we've used up some of the time already. Okay, so we're on item 9, and we'd like to welcome Sarah Coulter joining us as guardian of safer working hours, and as succinct a presenting of your report as you can, and then there'll be colleagues' questions. Thanks, Sarah.
Thank you. So quarter 2 covers what we call really the start of the year for resident doctors. You'll have to forgive me if I
Hang on a
slip
minute,
into...
Sarah, we can't hear you, sorry.
Oh, my mic is
Pete,
on.
can you raise the... Sorry, Sarah, would you start again?
Is that better?
Yes,
Yeah,
thanks.
perfect. Panicking, it was my end. So I was just saying that quarter 2 really represents the start of the year for resident doctors. And I'll make my apology now in case I revert back to the term junior doctor. We're all still getting used to the new terminology. So we always expect to see a bit of a peak in August and September as the doctors are just starting. They're starting life as a doctor. They're getting used to that. They're starting new jobs as well. So I always expect the peak. I wasn't entirely certain what was going to happen this year because we did have an increase in the foundation year doctors. I didn't know whether that would represent an increase in exception reporting because there's more doctors, or less exception reporting because there's more doctors on the ground. As it happens, the figures were very similar to last year, so I don't think it's really had an impact. The main issue this quarter, as far as I was concerned, really was the number of exception reports in surgery. This came to light in real time at the end of August, and it was raised with all the appropriate people in surgery, and no one really had an explanation as to what was happening. They had extra doctors on the ground for the first few weeks, so we certainly can't blame that. This is just something we're going to need to continue to monitor. Different departments do have their peaks and troughs, so I don't tend to get too worried about it if it's just an isolated incident. And then kind of the explanation for that is endocrine. I was worried about endocrine at the end of last quarter, and actually they've turned themselves around and now they hardly got any exception reports. So that's a positive. A slight area of concern I did have was when I found that some departments were offering ADHs rather than getting the doctors to exception report. I don't think that was done with the intention of deliberately misleading what was happening from staying late. I think they thought that they were paying the doctors more and they were doing the right thing for the doctors by doing that. Anyway, we've explained that why that can't happen. One, it creates a 2-tier system where some people are paid ADH and some people are just paid their normal hours, which is not fair. But it also means that I was not able to monitor the extra hours that they were working. And I'm joining the rota coordinators meeting at the end of this month just to really emphasise why we can't be doing that moving forwards. That's probably all I need to say, actually, but very happy to take questions as always.
Lovely. Thank you very much, Sarah. And just to help me, what does ADH mean?
Additional duty hours. So it's kind of the locum rate, sorry. Yeah.
No worries. No, that's fine. Thank you very much for that. And again, a really full report. Thank you. Colleagues, are there questions for Sarah? Robin.
Thank you, Sarah. I put a little asterisk next to that comment you made in the report around the use of ADH additional hours. Is there anything I need to support with that conversation to encourage people to use the right reporting? Because or is that something that you're content you can manage for your route?
Maybe. We have raised it now with the relevant people. We're going to do another snapshot in a few months' time as to what extra ADHs have been paid. And if it's still an issue, then I'm probably going to need a bit more support with it. But I'm happy to run with it for now.
Brilliant. So if you do, just give us a call. I'm happy to be part of that conversation. Thank you, Sarah.
Right. Thank you.
Thanks, Rob. Alison.
Yeah, on the ADH issue, Sarah, we can also ask the rostering team for some support to try and identify any issues very quickly. On the second question for me really is on the induction issue. Is that the first time that you've seen that happen? Is it a one-off? Or has it happened before? And is there something that the training team can do to support as well on the induction issue? Thank you.
Great question, because it does crop up quite regularly. usually we know about it in advance, so we can speak to the relevant departments and see whether they can have their existing doctors cover the period over induction. It's a bit more tricky if we've got incoming doctors from different hospitals, but it's the first time I'd heard about it from the community hospitals, and we only found out about it after the event as well, so there was nothing we could have done to rectify it.
Thanks, Sarah. Aled.
Thank you. I think it's just interesting reflection on the number of exception reports per month and what that demonstrates. Since 2021, there's been an increase, and that's been sustained into this year. And I don't think that in some ways, in terms of voice in an organisation, is actually a positive thing, because it demonstrates feedback, which is what we want. The underlying causation of that is actually what we need to dig into. And then further on that page, bottom of page 5, just caught my eye again. Actually, I think we've picked this up before around the fear of detriment around reporting, and whether Richard, myself, Joe, kind of bring this into the FTSU, Freedom Speak Up, sort of conversation around that, given that it's different but related obviously to voice again. So that would be something really interesting to pick up on as an issue looking ahead.
Yeah, thank you for that, Aled, because I was going to pick that up as well and wonder. I know there was a kind offer from Kim at the last meeting about liaising, just wondering whether that's making any difference. But also, if I might just add my piece there, and what action we might be taking about the advice not to exception report, which was also on that page. So, Sarah, how did that go?
When not to exception report versus ADHs. Was that the question?
Well, no, somewhere further down on page 5, I think it is, that the people are being advised not to exception report.
Yeah, so it was an anonymous survey, unfortunately. I mean, the foundation year doctors are not too worried to exception report of that, I'm certain. I still think it's a cultural thing, not necessarily. A lot of these doctors did not grow up with exception reporting. They still find it quite an alien concept. So I think some of it is that they worry about exception reporting more than the consultants worry about them exception reporting. Anonymously, I've not had anyone come to me. I've not had anyone come to any of the other junior doctors resident doctors about it. So I genuinely don't know whether it's just unfounded.
And how did the link up with Kim go, or with Joe Burton, the FTSU? I don't know if you'd had time to do that yet.
No, we tried and we couldn't do it with our annual leave, but I think we're trying to do it after our monthly meetings. One of them's this week. I don't know whether Joe's going to be able to get to that, but no, we have been trying to meet up, but clearly we both take too much leave.
I'm sure you don't. Kim?
Yeah, so hopefully Joe will be able, I think it's just the lie of the land, as you say. However, in the meantime, Sarah, Joe has done just two walkarounds in ED and taken the opportunity to talk to all members of staff as regards, not just how they're feeling, their health and well-being, any concerns, the role of DATEX or exception reporting. So she's been quite visible, but as you say, it's really difficult with anonymous surveys to get to the root cause. I had one the other day that just said, I'm really sorry, I had a bad day, but at least they came back to me. But we'll keep that going in the meantime until we meet up.
That's great, thanks, Kim. Ian?
Yeah, thank you, Sarah. I just wanted to follow up on the general surgery increase that you referenced. So if we look at this, I know we receive this report quarterly. The number in that area over the last quarter was 67 compared to 12 in the first quarter, and even compared to last year's Q2, it's more than doubled. So just for my benefit, how are you intending on getting assurance that that's heading in the right direction in October and November? Conscious as a board, we won't see it until the Q3 report, and we might have seen another trend of a series of months at a high level. So just a bit more on that, if you may.
Yeah, I mean, it's difficult because we've not really been able to nail down why we think it's happened. We've spoken to the relevant people about it. The only thing that maybe is flagging up, and I'm going to speak to the special lead and CD about it, is late ward rounds. So it's some of them consultants not starting the ward rounds till 4, wanting the doctors to stay with the ward round, and then they've got lots of jobs at the end of the day. So that's certainly one area that they need to look at. And it's probably worth me having a meeting. I have summarised all of the surgical exception reports so that they can have a look through them, see whether they can come up with themes as well themselves. So certainly the earlier ward rounds would help. And do they need everyone on the ward round as well? Can different members of the team be peeling off and doing the jobs? It's just kind of how structuring the ward rounds. Now, I don't want to teach them how to suck eggs, that's the problem. But it's just, yeah, you're right, that something different has happened, and it's trying to help them work out what's happened and how they can change it positively.
Thank you, Sarah. Thank you. Are there any further questions for Sarah? No. Can I thank you again, Sarah, not just for the report, but for the work that you do on this. It's really important. And as you said at the outset of your comments, we're getting people in their first real experience of working and working life, and we're definitely planning cultures for the future. So to get people to understand that it's okay is really important work. So thank you very much for your report, and we'll look forward to the next one. Thank you. Is Jo there? What we're asked to do then, please, is to receive and note the Q2 report from the Guardian of Safe Working Hours, and to note, Rob, your offer to link up with Sarah should that be required. Thank you. And if Jo isn't there, we'll do a bit more quality. Oh, she is. That's marvellous. Thank you, Jo. Welcome as ever. And thank you for your report. Would you like to give us a brief introduction to it?
Yeah, thank you, Chair. Assuming everyone's read the report, there are 3 main parts I'd like to highlight this month. So while we are beginning to see a reduction in anonymous cases, I still really recognise that we have a lot more work to do. I think as an organisation, we are speaking a lot more about how to speaking up, my role, which is really positive. And also it's featuring in our new leadership programme, some of our new lead training programmes. So that's really positive. And I've also noticed as well over the past couple of months, a lot more invites from teams throughout all 3 organisations asking me to come and talk, not just about my role, but about all the different ways that we offer as an organisation to speak up, of which there are many. So that's really positive, I think, and I hope has maybe played a part in reducing some of those anonymous concerns, because obviously our whole energy is about going into people being able to feel safe and comfortable to come and sit and have a friendly conversation with someone. So the second point, you'll see in the report, I gave an overview of a case that Kim and I handled in the neonatal department. And I just wanted to kind of summarise that really. And from my point of view as Guardian, that case flowed so well and was dealt with really, really quickly. And I believe that was because our safety lead, our exec lead for speaking up, the safety lead in the neonatal department, and Kim, we really all worked together collaboratively, and it was just acted on really quickly. Lots of different conversations happened in the department. It felt like they really welcomed the concern. They were curious about it. They were open to the learning that it kind of identified. And it felt to me, and also to the person who has spoken up as well, a really healthy process. And I think it just really highlighted for me as well the importance of my relationship with Kim as exec lead. You know, I sometimes need to phone Kim at really odd times to get advice. And it's just really important that I can do that and that we can all work as a team. I feel that this was a brilliant example of how all freedom to speak up cases should be handled. Sometimes, though, I find myself waiting quite a long time for feedback. And in this case, which they're often quite complex to coordinate, if you're waiting a longer time for feedback, it's often, really difficult for the person who's raised the concern as well. So to do things really thoroughly and sensitively, but in a really timely manner is really, really important. And then the third thing, and I know I just came in on the end of the last conversation, but you'll have all noticed in my report that for the first time in 5 years, we're hearing more from doctors, which is positive in terms of doctors are speaking up more. So I've got some joint working with the GMC planned in the new year, in the early new year, for our resident doctors. So we'll be providing them with a Raising Concerns workshop. I'm also personally forming a stronger relationship with the education team in the postgrad centre, so that we can do all we can to support doctors. And I'm also on the lookout to recruit some doctors to become champions, because we have a wide variety of champions in our network, but we do not have anyone who is a doctor. So it'd be really good to recruit some doctors. And then just lastly, I think you'll have watched the new Freedom to Speak Up video in the break. And I just wanted to say a thank you to Charlie and Pete, who obviously put that video together, but made it a really fun couple of hours for all the people involved. So thank you to them.
Thank you very much, Jo, and absolutely echo that. And we did have the opportunity to see that video at the beginning of the meeting. So, gosh, there's a load of hands gone up, so that's lovely. Isabel, you first.
Oh, I thought I'd better get in quick, because I know that I thought there might be quite a few hands, because this is such an important paper. And Jo, can I just say thank you again? I mean, you're just amazing, the work that you're doing and your team and all the champions. So thank you. I had two quick things to raise. The first time you mentioned about doctors raising the largest number of concerns for the first time in 5 years. And I wonder whether you feel that there is any impact from all the industrial action that may be prompting our doctors to want to raise concerns. So to get your thoughts on that would be really good. And the second point I wanted to raise was around the link between the Freedom to Speak Up work and the Compassionate Leadership Programme. And it's really encouraging to see that we've got the numbers taking up that programme. But I wondered what you might think about wanting to do in terms of strengthening the link between Freedom to Speak Up and recommendations, referrals, in a sense, through to compassionate leadership programmes and other initiatives.
Yeah, thank you, Isabel. So I definitely think the industrial has had an impact on doctors speaking up, but actually I've seen a variety of doctors speaking up about a variety of concerns as well. So there's lots of different concerns coming up from different levels. Yeah, so really interesting, and I'm just glad to be starting to have those conversations. But yes, I definitely think the industrial action has impacted it. In terms of the Compassionate Leadership course, which I have just started actually, so I did the first session last week. I would love to see all of our staff do that course. I mean, yeah, and we actually had conversations about this on Monday when I was, as part of the course, because often what we find with these courses is that sometimes we get our staff there who are already, in terms of culture, really contributing to that, and it would just be great for it to be extended to all staff. Yeah. So I think it's really, really good. And we had some really good conversations on Monday. And I think there's over 100 people who've been trained now. So really, really positive.
Thank you. Thanks, Jo.
Time, I'm going to take 2 questions and then another 2 questions and then ask you to respond if you would. So if I could take Mary and Ian and then ask you to respond. Thanks.
I just wanted to follow on from Isabel's point around the doctors utilising the freedom to speak up channels. Really, it's a comment as somebody with fresh eyes. This is something that a lot of trusts struggle with. And I think that you are seeing the doctors reaching out to the freedom to speak up is real testament to the way you've embedded your service and the work that you've done. It isn't something that everywhere is achieving, and I say that from experience. And I'm very happy to work with you around trying to get some medical champions.
That's great. Thank you, Mary. That's a really great offer. Ian.
Yeah, thank you, Mary. So I just wanted to echo I think the video is fantastic, Jo. I watched it as part of the pack, and obviously it's been played as part of the board meeting today, which I think is really powerful. Freedom to Speak Up month last month, I was fortunate board members to join Jo on a walk around, and I think I wanted to share the fact that I was really, really pleased to see in the areas I went to how many people were aware of Freedom to Speak Up, how many people knew their champion in their area. And the routes available, and how comfortable people felt speaking to an exec walking around their area about difficult issues and freedom to speak up. So it was just, again, to echo and build on what Mary's just said in terms of that's testament to all the hard work of you, Jo, and the team, and the champions across our hospital. So thank you.
Do you want to respond to those 2, Jo, or should we push on?
You can push on if you like, but I'll just quickly say thank you to Mary and nice to meet you. And it'd be good to talk further. And Ian, it was good to do the walk around with you too. And yeah, it was a really worthwhile. It's always worthwhile going out and about in our hospital and having those conversations with colleagues. Thank you.
Thank you, Jo. Richard Kay.
Thanks, Mary. Thank you so much, Jo. Really rich report as ever. I like the word of curiosity that you used. It's a really important, critical attribute of strong leadership, and being open to change is really important. Just 2 questions. I noticed about low completion rates for training, and it's important that leaders at the trust model compliance. So I just wanted to get your view how we can improve completion rates for training. And also you talked about international nurses and speaking up. And is there anything that we can do at the board to support your work in this area?
Thanks, Richard.
Can I just take one more just to help us a little bit? Adrian, if you go next.
Richard's just covered it. I was just putting it in the chat.
Oh, that's perfect. Okay, Jo, do you want to respond?
Yes. So with the mandatory training, we have done communication about mandatory training in the past, why it's important, etc., etc. And the rates for managers are particularly low, like you've highlighted, Richard. So I'm not sure what else I can do as the Guardian. I think maybe some more communication, but just some encouragement from everyone to get that completed, I think would be good. It's a really worthwhile training package. And the other question was about international nurses, wasn't it? So yes, it's a group of colleagues who Kim and I have met with in the past. So I think there's continual work. I'm assured that there's continual work going on, and I'm in regular communication about that. To make our hospital a better place for everyone to work in. What I'm really fortunate to have is some of our international nurses as champions, and regularly meet with them about challenges and escalate that. I'm sure Kim will have something to say on this as well, but yeah, thank you.
Kim, will you come in on that point? Go ahead.
Sorry, I couldn't get myself off mute. That wasn't a good start. So yes, I meet myself or one of my team meet every single contingent of our globally educated staff coming in. Freedom to speak up is one of the first things we speak about, because we know culturally it sometimes is a very, very unique opportunity, and the first time that they get to hear about it. I think, building on to what Mary says, it's been interesting because some of our globally educated doctors and others have now reached out because of the work we're doing with the non-medical. So getting that connection, Mary, will be really great, I think. And it's amazing now, I think, being 7-8 years down that line of recruitment with nursing and seeing the growth in other areas. As Jo says, we now have some of our BAME colleagues and other globally educated in the champion role, and that further demystifies what the role is and what it isn't, and how it's available for everyone, and how we spread that word is really important.
Thanks, Kim. And so lastly, if I could take Alison and then Adam, and then Jo, if you could respond to those two. So Alison, you first.
Yeah, I mean, the first thing I want to say is thank you to Jo and Kim for the excellent relationships that we've got with the people in OD team, in particular, the people experience team and the EDI team, because as the report indicates, sometimes we do need to look at HR processes as a consequence of that freedom to speak up issue. The second thing, I just want to sort of suppose challenge us a little bit on pack page 102 out of 599, when we categorise the concern, and we've got quite big red blocks on process. And I wondered, Jo, whether we could do some more work, because that could almost be hiding, by categorising things as process, it could be hiding actually, is there inaction from a manager, or is it actually that our policy or process doesn't work? So I wouldn't mind doing some more work with you on that, so that we had less falling into that general category of process. Thank you.
Yes, of course.
Adam?
Thank you, Mary. Thank you, Jo. It's a question about the section in the report on triangulation. It's great to see that we're working with Derriford in Plymouth. I just wondered if you could say a bit more, please, about what we've done as a result of that joint work, or what we're planning to do as a result of that joint work.
Yeah, thanks, Adam. So that's in process. So currently, myself, our Naomi Burden, Jem Robertson, Bernie, we're all kind of joining. We've all been invited to the meeting they hold at Derriford. So we're all taking a turn and we've been invited to those meetings just to be part of that meeting and really understand how it would benefit us as an organisation in terms of triangulation, and me being, well, and everyone else who's going to attend it, being assured that we are dealing with things. I mean, from my point of view, the freedom to speak up things as well as we possibly can. So it's still in process, Adam.
Okay, thank you.
Thanks, Jo. And you've picked up Alison's point. Jo, can I just repeat what I know you've heard? And I can't believe, is it 3 years or 2 years you've been in this role? But it's
5. Yeah.
There you go. Doesn't time fly? But how wonderfully I think this whole role has developed since that you've been in it. And I know you get a lot of thanks from the board, and we really do mean it. You've heard the words said today, amazing and brilliant. Thank you very much for you and your team, because you also manage a large team of very able people. So we thank you very much for this report. And I can't believe it's 5 years, but there we are. Thank you very much.
Thanks, Mari.
And what we're asked to do, please, is to note the key issues identified in the report, to discuss for assurance the latest trends, as I think we have, and to note a feedback coming from colleagues, and also just to note the offers across between Alison and Mary, as well as Kim. So if colleagues would be happy to do that, please. We will come on to continuation of our quality section, and we are now on to section 11.1, where we're going to invite you, Kim, please briefly to give us the maternity and neonatal safety report.
Thank you, Chair. And just to note for members of the public, this, as you said, a lot of the heavy lifting and discussion happens at our Quality Assurance Committee. I will just raise a couple of points. Our neonatal staffing has been a matter of concern, and you'll have heard me speak about this before. It was further complicated by a high rate of maternity leave within our staff group, but that pushed our what I would call our overall vacancy for 32% between vacancies, maternity leave and sickness and absence. So we have comprehensively looked at this with our senior medical and nursing and the safety champion in neonates. So we completed a comprehensive risk assessment. We had a look at current mitigation and what further mitigation we could take. And we also had a look, because some of this was quite, with Agenda for Change, some of it could look like we were trying to potentially break the Agenda for Change, which was a concern. So we also spoke to regional colleagues as well as regards how they were handling some of the vacancies, noting that neonatal nurses and their skills are few and far between. So what did we do that absolutely helped us? So I'm pleased to say at the moment we have reached an agreement as regards enhancements for the ward, and I'm going to say ward based because that covers that cohort of staff, but we've also looked at a enhancement rate for advanced neonatal specialists because they're already on our doctor rota, and we've got medical vacancies and nursing vacancies. So without tipping either, how did we collectively come together? And those two mitigations are in place, and we're meeting regularly to see, is it having the impact that it needs to have, and what further do we need to do? There's a lot of operational mitigation in place as well that's holding this, and we've currently got an open advert out to have a look at what skills or what colleagues across the board that we can attract into the service, and we'll keep a close eye on that. I'm really delighted to see for the first time, and there's still work to do, on page 147 we've now got the ethnicity at birth, and we're able to demonstrate some of that. That still needs refining, and we know that the ethnicity demographic reporting is a challenge across the trust and in many areas, but we'll keep going. That also enables us, because remember we've got the vulnerable team of the team looking after those with vulnerabilities, which include our BAME parents, absolutely working with them, and we should be able to start tying whether the actions they're taking are making a difference on outcomes as well now as we go forward. I did report on the triangulation meeting that's now in place, and that's really important and a testament of the ongoing culture. So we'd picked up in complaints that whilst there were few and far between clinical concerns, actually what was coming out, which we were curious about and very professionally curious, was attitudes, behaviours, and some of our mums not feeling listened to. So that triangulation is now in place with a multi-professional cohort of staff. There's dedicated shop floor champions that go there, and I think when I did an exec board round, Richard and another member of the board were there to make sure, and they saw that in action. But actually what some of that outcomes is staff, especially in the postnatal ward, were feeling really pressurized as regards the levels of documentation, the complexity still of having written as well as IT, and then having because it's a place that's quite high demand and nobody really wants to be there, and there's concerns about you want to go home with your baby but you're not quite there yet, and so we had a really good conversation about what else could we do that could alleviate some of that pressure. And the silent call bell has been testament to that as well, getting the right person there, not causing further disruption, and that's had positive feedback. So already we're seeing some of that coming through. The only other thing I would like to raise is we've completed our maternity improvement plan, noting that's only one improvement plan, but it's really testament to the team and their ongoing work as regards being curious, taking actions, ongoing, but most importantly, completing and sustaining. But as you will see in the report, we have other plans or analysis to do, and those will continue to report. And I shall leave it there.
Thank you, Kim, as ever, a really full report and a very helpful précis there. So I really appreciate it. And you picked up a point that I was going to make about being heard. So that's really helpful. Colleagues, do you have questions further to those already asked at Quality Committee for Kim at all? Adam.
Thank you, Kim. It was great to see, and you just mentioned it, that the 21 actions from the CQC action plan have been delivered. I think we need to take a moment and celebrate that. That's really good. So thank you for emphasising that. The one question is around the paper makes clear that there's still a couple of posts that require funding, and the funding hasn't been agreed, and makes reference to a business case being escalated through the trust process. Could Kim or Ian perhaps explain what does that mean, and when can we expect that to reach a conclusion, please?
Ian, do you want to pick that up?
Yeah, I can do, and Kim, feel free to add to it. So I met with Bernie yesterday, actually, Adam, on this particular topic, so Kim's deputy. So this relates to the extra elements of investment needed to enable us to secure our CNST Year 6 compliance, and primarily is in two elements: neonatal nursing staffing, and 2 elements as well around medical staffing. So I met with Bernie yesterday to understand that there's been a business case drafted that's going to go to our investment group on the 18th of November, and subject to the values of that, it will then enter into the double lock process. So we look at this every year, and this is part of a kind of a sustained period of investment over a number of years linked to the Ockenden standards and the maternity safety standards. So it's a process that's fairly well established over previous years, and we'll be taking it through that point. I think that there will be a challenge, particularly if we are in a position where we're able to approve that and secure the CNST premium benefit that we get if we hit the Year 6 standards. There will be a challenge, I assume, around the recruitment, recognising the position, particularly on the neonatal nursing staff side of things that was picked out in the report. But Kim, I don't know if there's anything you wanted to add to that.
No, I think we're all prepared to go, aren't we? I think there will be check and challenge, but I will speak to my counterpart in the system before it goes there. This is about achieving the CNST compliance, and there's higher reputational risk and potential safety risk about not being able to fund this. But we're absolutely prepared. I think it is also acknowledging, Adam, that actually we've been able to, using the process, change, reskill mixing and other things, we've been able to mitigate it this far, and this is the planned next step, which is on track, and we'll keep an eye on it. Recruitment will be a challenge, as we all know. Even having the money, recruitment has continued to be a challenge, especially in neonates. And whilst we're extremely fortunate and currently have no midwifery vacancies, it has been a challenging period for them as well, with high maternity leave to consider as well as. But I'm pleased to say that that there is no vacancies in our midwifery section at the moment, so we need to continue to keep going.
Last word to you, Isabel.
Thank you. Yes, I just wanted to get assurance at board level. I mean, we have discussed this through the Quality Committee, that we are doing everything we possibly can in terms of incentivising our current workforce, given that the time frame for agreeing anything that goes into double lock process is fairly lengthy, and we have the immediate pressure particularly for our neonatal staff to continue whilst that decision's being made.
Satisfied at committee that we are, Isabel?
I beg your pardon, I didn't hear you.
Was the committee satisfied that we are doing everything we can?
I think we've got some outstanding issues around what might be available in terms of supporting those members of staff.
Isabel, those are the two actions we've done with enhanced payment. So we've agreed in line with doing what the rest of the network are doing as regard giving those enhancements, and those are currently in place.
Thank you, Kim. That was the answer I was hoping for.
Well done. Thank you very much. Okay, colleagues, thank you. We are asked to note the situation, background, assessment, recommendation, decision, neonate staffing issues and mitigations. Asked to note the current position in relation to the clinical negligence scheme for trusts, and asked to note the Quality Assurance Committee have reviewed the perinatal mortality review tool quarterly report, and there are no escalations. Finally, to note the completion of the maternity action plan and to celebrate it, as Adam said. So, colleagues, if you'd please indicate in the chat to that. I'll come to Mary for the Learning from Deaths Q1 report. Thank you.
Thank you. So I'll take the report as read, and I'll pick up what I think are the key points. I'm happy to take questions afterwards, with the caveat that if I can't answer them at this point, I'm happy to either take them outside of the meeting or bring them back. So our HSMR has decreased to 98.94, which is the rolling period of 12 months to May 24. And actually, that's part of a gradual reduction and stabilisation over the last 24 months. Our shimmy is stable at 102, with quarterly reporting over the 12 months to March 24. We don't have any regional themed alerts. We have 2 alerts for RCHT, one being syncope, with 5 patients dying coded at a syncope between August and December 23. Recoding has brought this down to 3, and the mortality review oversight group will continue to monitor that. But thus far, there's been no themes or concerns picked up through their reviews. Ella's already mentioned the concerns around fractured neck of femur and the fact that we've got an improvement group looking at that. Fractured neck of femur is still flagging as an alert. The heat map that we've got shows a negative trend over about the past 12 months or thereabouts. Particular issue is getting to surgery within 36 hours, and we're benchmarking in the bottom quartile for that. Ella's mentioned the improvement perfect week that's planned on the back of the flow work that's being done, and we will continue to make sure that that's top of the agenda in terms of keeping an eye on that. Looking at the medical examiner office, in Q1, 96% of RCHT inpatient deaths were scrutinised by the medical examiner, which is good. Because of some preemptive work that the ME office did around the changes to the national death certification process that came in from September, there have been no specific concerns flagged because of those changes. And I think that there's a summary in the report for people to read about what those changes actually are. We've had 106 coroner referrals in the period covered, with no preventing future deaths notices in that period. There is detail within the report of 2 concluded coroner's inquests that took place in March 24, where ambulance delays were felt to have contributed materially to those deaths. And following that, there were a number of actions set out and undertaken by RCHT, and more details are in the report. We had 38 referrals in the period referred to the patient safety team for review. Looking specifically at mortality reviews, there were 26 reviews during that Q1 reporting period. 7 were priority reviews. I think one of the points I'd really like to highlight to the board is the learning that has come as a result of those reviews. And importantly, and something that is sometimes hard to achieve, tracking of the feedback to the relevant care groups so that they can actually act upon that learning. So I think important, and I'm glad that we're managing to achieve that. One of those reviews demonstrated or was felt to demonstrate strong evidence of avoidability, and as a result of that there was an after-action review. There's been a protocol development specifically looking at the initial management of patients presenting with liver failure to address the issues and the learning within that case. Specialty-specific mortality reviews are held, and the CMO office will continue to support the teams to make sure that they are undertaken in a timely and thorough fashion, that we're getting the learning fed back to the clinical teams. Looking at perinatal mortality, there were 3 deaths in Q1, all of which have been looked at under the PMRT process, which is a perinatal mortality review process, with actions and action plans agreed and monitored for all of those, and they will be looked at in the mortality review oversight group to ensure that we've got that assurance around those processes. And then finally, 5 deaths occurred in Q1 with patients with autistic spectrum disorder and or learning disabilities. All those cases have been reviewed and good care has been noted across the board. So happy to take questions insofar as I can answer them at this point.
That's really helpful. Thank you. Colleagues, are there questions for Mary? I think you've done a great job considering this is your first week. Goodness me, well done. I have a question, but I've also got Isabel, Richard, Ian and Adam. Isabel.
Thank you. Mine isn't really a question, it's a comment, and say well done, Mary. That's amazing in the first week. But just wanted to pay tribute from the board, on behalf of the board, to the Mortality Oversight Group, because they do really amazing work, and the Quality Assurance Committee is able to take full assurance from the reports that come through to us on a regular basis. So thank you for all the work that's going on within difficult circumstances where I know they've been very short of people to be able to undertake that meeting recently. So yeah, thank you very much.
Thank you, Isabel. Richard, I might piggyback on what I guess might be your question, or if it's not, I'll ask an additional one. So if you could go next, please.
From my reading going on. First of all, most lovely to meet you, and hope we. Sorry, I'm not there in person. My question was on learning disability and health inequalities. It's a bit operational, and I apologise for that. But I think from a health inequality perspective, I would hope we could report on cases that look at the trends for avoidable and unavoidable deaths, because I think that's quite important where there's a lead-of review, and also to have full data on ethnicity and deprivation in line with how we report for other patients.
Just take the opportunity to piggyback on that, Richard, on a slightly different point, and I might have missed it in the report, but with the last comments you made about the 5 deaths, I was wondering whether the annual health review for those people, do we know whether the annual health review for those people who died had actually taken place? And it's probably a community question, but
I can find out. I don't know the answer to that question, but I can certainly find out.
That would be really helpful. Thank you, because I think it's patchy as to what happens in the community, and it would be possibly related. So thank you for that. Ian, you next, and then Adam.
Yeah, thank you, Mary. So I just wanted to check, mine was relating to the changes in death certification. So Alistair had previously kind of cited the board on those changes, and I know they're coming in a couple of phases, but it was just specifically the question on page 168 in the pack where it talks about all of the changes. How are we going to have the assurance through routes into board in terms of those changes have been enacted and the various steps that now need to be taken are being taken and we're complying with those new processes? So you might not have time, it might not be one you can answer now, but it's useful to understand at some point how we're going to track that and have the assurance that the changes have been embedded.
I think that information is going to come from our medical examiner's office, and I'm very happy to have that dialogue to make sure that, you know, subsequently the learning from deaths report reflects that we've got that assurance and flags any issues.
Thanks, Mary. Adam?
Thank you, and my question might reveal my lack of understanding of the topic, but section 3.7 gives us an analysis of speciality mortality meetings by speciality, and I was just, if you could say a bit more, we'll come back on who decides how frequent those meetings are, what the consequences or implications are if those meetings aren't actually held as well?
Well, I'll answer the first question. I can find out for you. In terms of what happens, the problem is then you get a lag in the learning essentially, and then it's less meaningful because time has passed, the relevant staff have moved on, and I feel that it loses quite a lot of its meaning and general legitimacy at that point. So that is the problem with letting them lapse. As to who decides the frequency, I can't tell you. You'll look and see that the vast majority are fairly frequent, and there are a couple of specialties that, for reasons, and I can't tell you what those reasons are, have decided to go to quarterly or less frequently. I don't know what the rationale behind that is, or whether they've got a mechanism to ensure that they are capturing the learning and feeding that back, and I will look into that, because it's already something that while I was looking at the report I'd already flagged as a bit of a question mark, but I don't have the answer for you now.
That's great, thank you.
Thanks.
Mary, and I think, Isabel, you wanted to come back. Last speaker again, please.
No, it was only just to provide a little bit of assurance to Adam that this was something that we flagged at the last meeting when we looked at this report, and in particular picking up where, for example, oncology don't appear to have had any meetings at all. So we've asked for further information to come back to our next Learning from Deaths report to provide us with greater assurance around the frequency of the meetings, the purpose and the outcomes.
That's great. Thank you very much, Isabel. So, colleagues, if there aren't any more, then could I thank you for that report, Mary, and ask us to note and endorse the Learning from Deaths Q1 assurance report as part of our assurance arrangements, and ask you, Kim, if you could come on to briefly as possible to 11.3, the annual complaints report.
Yes, so I will be very succinct, noting that some of the issues we've already covered as part of the board story. I would like to take just a minute to acknowledge the 100% compliance rate as regards acknowledging a complaint within 3 working days. That's been a huge improvement on part of, now that the team has been fully established. We were struggling a little bit last year. Also noting that formal complaints responded to has achieved 95% or more for 6 months of the year, and for 3 months of those it was 100%, and that's an increase of 6.5% on the previous year. Noting there's still more work to do, and throughout the continued operational pressure, you know, the support the central team need to be able to give the care groups here, often when they are complex complaints that span more than one care group, makes it difficult. We had 15 complaints that went to the Parliamentary Health Ombudsman, which is an increase of 4 received, and these reflect the complexity often of these cases now, and sometimes they're not just across care groups, they're across systems such as CFT, RCHT and SWAST, so we keep a close eye on that. It's noting that we now have the K41, which is a reporting data platform, which is really good to see. However, we will be looking now how we benchmark. We often have had that question, how do you fit in? How do you know where you are? This database should be able to now, we'll be able to have a look at some benchmark data, and we'll be able to include those in future reports. And we had a low number of respondents from our staff as regards the complaint process this year, and I think that's a sign as many as regards the pressure that staff are under and time to be able to complete surveys. So we're just looking at our next patient experience group. What do we do that could be maybe quicker, smarter? How do we reapproach it? And how, with all the other surveys going on, as Alison and I know, how do we time that so we can get the best response possible? Because actually we absolutely need that feedback, and I'll leave it there.
Very much, Kim. Are there further questions for Kim on that? Yep, Adam.
Thank you, Kim. sorry, you may have just mentioned this, but it just felt like it would be useful perhaps for next year's report, apologies if I've missed it, to say something about what process we go through to give people every possible opportunity to raise a complaint, and how that could be improved even further through benchmarking perhaps. So I don't know if you want to say anything about that, but it feels like that would be a useful section to have in the report.
Yeah, I think now we've, yeah, you're right, Adam. Now we've got the platform, it will be easier to do that benchmarking, and then having that opportunity as we can to have a look at where they've got better practice or best practice, and how do we use that in our processes, and fully acknowledging, as you heard me speaking about before, every level of opportunity you get before you have to get to the last resort of what I call formal complaints, which is always far more upsetting for our patients and their families, as opposed to being able to do what I call real-time resolution.
Thank you, Kim. Steve.
Yeah, thank you, Kim. Excellent report. And you identified right at the start the challenges around same-sex accommodation breaches, and there's a lot of information in the report. I just wanted to test, do we believe that the actions that we've set out in partnership with CFT and RCHT, and the internal RCHT actions designed to improve patient flow, are they sufficient to enable us to reduce significantly the frequency of those same-sex accommodation breaches, or is there anything else we need to do as an organisation?
So, Steve, it's a really good question. All of the detail outlined in the report will get us back to. This is the first year that we have reported same-sex breaches, and all of it is linked to our escalation, and the steps to de-escalate included in this should enable us in both organisations to bring that down, if not eradicate, which would be great to see.
Yeah, because you're right to point out, Kim, that this is the first year we've had to report this, and so that's greatly to our credit, but quite right to get it back on track. So, colleagues, thank you for that. We're asked to approve the annual complaints report and to note for assurance the Trust's mixed-sex accommodation position over the last year and Kim's comments on getting it back on track. Thank you, colleagues. That brings us to welcoming Sarah Jarvis for our organ donation annual report. So I think you're here, Sarah. And so thank you very much for joining us. Thank you very much for the report. And I did particularly want us to have the report at board, really to recognise the work that you and your teams, plural, do behind the scenes on this really very difficult subject. So if you would like to give us your report as succinctly as possible, please.
Absolutely. Thank you very much for inviting me. So I'll take, as you said, the report as read and give you the highlights. I'm one of the intensivists from the unit here, and also clinical lead for organ donation. The main highlights, which you will have noted, is that we were able to support 5 patients proceeding to organ donation in the year 23 to 24, so it's April to April. And this resulted in 12 patients receiving transplants. So those were life-saving solid organ transplants that were able to be given by our patients here. In addition to that, 8 corneas, so tissue from eyes, were received by the NHS BT eye banks for transplant into people losing their sight around the UK. This data is gained from the potential donor audit, which you'll note in the report, and our main benchmarks or targets are that we are recognising and referring all donors who are potential donors, and that we're ensuring all families of patients who might be donors have the opportunity to discuss end-of-life wishes and organ donation with a specialist nurse in organ donation, and that pertains to the specific skill set that those nurses have in explaining the procedure and gaining consent. So in addition to those 5 donors that were able to proceed, there were 2 donors that weren't able to proceed, the details of which are in the report. but were for clinical reasons. And we were able to recognise 19 potential donors within the trust that year. Only 10 of them went on to meet referral criteria. We missed 3 patients who were not referred for to the donation hotlines. Those have been delved into, and the details of those are in the report, and sort of actions have been taken where they have been necessary. One of those of note was due to lack of capacity in critical care to admit for the time it takes to support a family through consent in the donation process. So withdrawal of life-sustaining treatment took place in the emergency department. And otherwise they were for clinical reasons once more. And there was only, in terms of the audit criteria that we're sort of standards were held against, only one conversation was had with a family where a SNOD wasn't physically present, and this was due to it being out of hours and the family themselves raising the topic before a SNOD could be brought from elsewhere in the country to be part of that conversation. So sort of out of the control of the local team. The second part of the report pertains to the education and training, which is about a third of our role as the organ donation team. Obviously, a lot of the clinical work is carried out by the RCHT departments themselves, theatres, ITU and ED. So education and training is undertaken by Becky Tolman, who's our specialist nurse in organ donation here, embedded in the ITU team. We were able last year to begin bringing our ITU mandatory training back in line, so they're having organ donation training on a monthly basis, so capturing all nursing staff again and supporting them with organ donation as a process on the unit. We are now teaching again more regularly within the theatres mandatory training as well to support the scrub and teams in theatres, supporting retrieval teams when they come from across the country to retrieve organs. And we've completed now an extra training program which was supporting our overseas staff. We had a sort of a large amount of ITU nursing recruitment over the last year and a half into vacancy, and we have supported those staff coming from other countries where organ donation is not necessarily part of the process there. And helping them to understand it and ask questions that weren't necessarily relevant to UK staff who've been used to organ donation in the long term. We've been supporting our anaesthetic trainees and our psychology teams by giving them teaching in organ donation, and also continue to support the SAGE and TIME courses, which run for all staff throughout the trust. And we've trained an extra member of staff at the Royal Cornwall Hospital now. This is an evidence-based course. It's for all staff, clinical and non-clinical, who are involved in end-of-life care, and patients who might be going nearing the end of their life. Any staff who are involved in complaints procedures or palliation of patients. Is a very well received course, and we'll continue to run it this year, supported by the Organ Donation Fund. And finally, promotion and remembrance for 23-24. During Organ Donation Week, we undertook the Race for Recipients, which is accumulation of kilometres by staff in the trust and outside in honour of donors, those on the waiting lists, and their families. We were second in the region in terms of the distances covered by our staff here. Rebecca Tolman, our SNOD, spoke on BBC Radio Cornwall Live during that to help raise awareness of organ donation, and 26 members of the RCHT group, with some support from the organ donation team, undertook the 3 Peaks Challenge in honour of organ donation and several other charities at the end of June last year. And there's some lovely photos which I can send to you if you'd like to see them. That summarises our report. I'm happy to take any questions. Yeah.
And a really great presentation of it. Thank you very much, Sarah, and thank you for the work you do, relatively new to this area. Colleagues, are there questions or comments on Sarah's report? Isabel and then Richard.
Sorry, I keep jumping in very quickly, but I just want to recognise how amazing Sarah and Becky are in leading this work. I had the pleasure of being the organ donation non-exec chair for a little while, and saw Sarah coming into post, and it's great to see how you're developing that post, Sarah. And Becky is just she's a force to be reckoned with. The work that she does is absolutely incredible. So you know, if you can pass thanks on to her, I would be very grateful. Thank you.
I will. Thank you.
Thank you, Isabel. Richard Stevenson.
Really, really good report. Always inspiring and humbling to a large extent. I guess there are 2 or 3 comments. One is there anything that we can do as a board, as an organisation, to better get 100% coverage of donors, and anything more we can do to promote? And on the, forgive my ignorance of the funding model, but are we linked into charitable organisations for some of our promotional work that we can do? Are we allowed to do that, use our trust charity to think of sponsorship and things of like the Surf Club, which is an amazing thing, but it's still where we get the funding from around that. And then there's a really pedantic question, which I apologise, Chair, which is the paper talks about endorsing the recommendations of the paper, and I wasn't sure what the recommendations were. So if I'm going to endorse it, can I be clear on what I'm endorsing?
I'm sure of that.
Thank you, sir.
My apologies. I didn't read out the recommendations for the paper. So they were to continue to support us in answer to your first question, how can we help make it everything 100%? And that's to continue to support GPICS level staffing in critical care. You know, we have very little nursing vacancy as of this financial year on ITU, so it's already really been met with respect to creating bed space and bed capacity to bring patients who are potential donors for prognostication and discussion, and the time it takes to go through the process with families to make sure everyone's comfortable with organ donation if it's a possibility for patients, and making sure we're staffed to have capacity essentially. I guess in terms of the only other thing, and it's not on that paper because Nina Cario was in post at that point as the chair, but would a non-exec chair would be fantastic. I'd love to work with one of you this year. So those are the sort of things to endorse. In answer to your next question was about the charitable side of it. So NHS Blood and Transfusion is not a charity. It's obviously part of the NHS body. My hours as the CLOD are paid separately without the trust. We receive a sort of a small stipend each year, which Becky and I and the chair use to run promotional work, and we're just quite savvy with it essentially. And we also use that money to support staff doing extra training courses, going to conferences, other things, sort of well-being and equipment for patients and relatives within all 3 departments, so ED, ITU and the theatres.
Thank you, Sarah. Thank you. And Matt has put a note in the chat. This is his first board meeting. He's only just joined us on the 1st of November. He's already been persuaded to be the chair of the Organ Donation Committee. So you will yet again. I don't know, Ian, if there's anything else that our charitable funds could be used. Could any of our charitable funds be used into organ donation or not?
So I think there is a specific organ donation fund, isn't there, Sarah?
Yeah, there is.
Is my understanding. So yeah, that's an active part of what we already do, Chair.
Great, thank you very much. Robin.
Thank you. To echo everything already said, just for reassurance to colleagues, we've updated our night planning process as part of our flow improvements, and that is working incredibly well. And one of the key questions that we assure ourselves of is, has ITU got staffing levels to GPICS requirements? Not always is the answer, as Sarah's alluding to, but it's absolutely front and centre each night. One of the questions we ask ourselves as an organisation. And then my other reason for my hand up was to volunteer Pete. Sorry, Pete, but actually, Sarah, could we get those photos of the work that you guys did? Because in our last board development session, we talked about the need to celebrate good news stories and share them out across our colleagues, and that sounds like one prime for that.
Absolutely. Hopefully you'll see a screen go up near the general office in the next couple of months, and we'll be scrolling those photos on it actively, continuously, with other organ donation information and positive stories about donation. But I will also send them all to who would like to receive them, and they can disseminate them to you all at some point.
To Lindsay.
Lindsay, absolutely. I'll send them to Lindsay.
Thank
No problem.
And just building that theme, although it will be your department, David, in future, not mine, but it is possible maybe in the next Organ Donation Week National, we could have a board story celebrating what we're doing and what we're achieving, because we haven't done that before on the board. So, colleagues, are there any other comments, questions? In which case, could we approve the report and continue to support the correct levels of staffing and bed occupancy to nationally improved standards, so the facilitation of the organ donation process can always happen? I've slightly amended that recommendation, Richard, to benefit from your comment. Thank you. And also, could we note the efforts of the Organ Donation Committee members and staff across the organisation in their support of organ donation activity? And may I say thank you very much indeed, Sarah, for the brought and for you being here.
Pleasure.
Thank you.
Thanks very much. Bye.
Right, okay, so that brings us to 11.5, I think. And Ella, this is the Research and Development Annual Report. If you could introduce that, please.
So as you say, it's an annual report, and it's reflecting on the year 2023-24. And I think it's fair to say, as I think people will pick up through the report, there is a slightly mixed bag. There are lots of achievements, which I will outline, and some challenges that the team have also faced. I think that's just really representing the fact that the research and development team and as a service is not immune to some of the challenges we see across the NHS more broadly around both the financial aspects and workforce challenges that we see. So as a team, they are really aware of those and putting in place strategies to handle them, which I will touch on in a little bit. But in terms of good news, I think it's really important we celebrate. This was the highest ever year of recruitment overall for R&D, so that's fantastic. And as a trust, we continue to really, I think we use the term slightly punch above our weight, which might be doing the team a disservice, because they are a really, really skilled team. But what we mean by that is really compared to some of our peers who have much larger research teams, the amount of recruitment we managed to achieve in this trust is fantastic. Also, so we remain the second highest in the region with that regard. We broadened out our spectrum of studies, which has been one of our kind of strategic aims, and we increased by 10% the breadth of studies we're doing across different specialties, which is really important to us as well. Our commercial income overall increased, but the activity decreased, and that's something we need to be really keeping an eye on, and the head of R&D is developing strategies to improve that already. Nationally, that's a trend, so we weren't massively out of kilter, but we did benchmark a little bit worse than peers in that regard, so we need to just keep an eye on that and try and get back on track. Some of the things sitting behind that was significant decline in things like vaccine trials, but also for us personally, some workforce challenges around services such as oncology, which we need strategies to address. Our KPI in terms of time to target performance declined, and is something we need to get back on track, because that's important in terms of us attracting funding. So again, the team are cognizant of that and putting in place a strategy there. The workforce challenges touched upon are things such as sickness and vacancy. No significant trends that I really need to pull out, but just things that individually are being managed, and I think I can provide the assurance, as in many teams that face those, the team are kind of addressing with the individuals and ensuring we're supporting people appropriately there. So one of the good news stories, and which actually links back to a discussion I think later from the we're having later in private board around the the charitable funds. So I noticed in one of the other papers a drive around for research funding, looking at promoting clinical fellows. And I think that is really, really important because this paper describes really clearly the impact that can have. So as a trust, we'd like to adopt that strategy of appointing more clinical fellows where we can. We've seen in cardiology the significant impact that's had on research. And we know in turn, the more research we're doing, the impact that has on quality of care overall. Yeah, so I think I can probably pause there. Actually, other than to say, it is important, I think we note in the last quarter, I think probably 3 months ago now, we took a financial deep dive to the Finance and Performance Committee on R&D because we'd noted that the forecast was significantly off track. Since then, they have pulled that forecast right round. I think we're now at only 20k deficit, which the team assure me will be in surplus very, very soon. So we're keeping a close eye on it. We're getting monthly updates at Finance and Performance Committee specifically on how R&D are doing within the overall finance report. And I think it's really important that we do have that focus, given we have really openly stated our intention around research and development and our clinical academic strategy more broadly and how important that is to us as the trust. And I think linking back to the discussion we had earlier on strategy, it's so important that we're clear we have the resources and we are aligning our financial plans to support our ambitions.
Thank you, Ola. That was a really helpful presentation. You actually picked up several of my questions, so I'll save a couple more. Richard, you first, and then... Thank you.
Really good report, and just always applaud the work that's been done by our R&D team. I think that has been a helpful deep dive into the finances, which has been useful to understand it, particularly when we start to think about income, whether it's gross or net. I think I had two comments, perhaps questions. One, I know it's an annual report, but as Ella's made clear, it's really important that we see this as a journey towards our ambition and our strategic intent, some of which is linked to University Hospital State, linked to standalone, has been a really strong research hospital, which will help to attract staff and recruit, etc. So it'd be really good to see on-year changes. So actually look at a trajectory from 3 years ago to where we are now towards our ambition. And I also wondered, is there a cluster of benchmark university hospitals that we should look to match our aspiration so that we can, again, just test our journey towards our ambition by using some benchmark hospitals, I keep wanting to say universities, benchmark hospitals that will help us understand how well we're doing against our ambition.
Thank you, Richard. Really helpful. And interesting, Kim and I had a briefing with the Lord Lieutenant and a range of his deputies this week. And one of the things they were quite hotly picking up on was why we haven't met the research target in order to. And we were able to give them some assurance, but that would also give assurance, I'm sure. Thank you. Aled.
Thanks. I think it's a really positive report. My main point was about learning from the cardiology fellow, which you've already addressed, and we're going to sort of look at that maybe further on this afternoon. But that is a really excellent test of change and demonstrates what can be done with investment, and the return on that investment is really useful to capture. And then map it across to those other areas. Also acknowledging the 50% of the activities undertaken by nurses, midwives and allied health professionals as well. That's a really good balance, which is untypical and good because of that. So, yeah, I thought it was really good acknowledging the difficulties. I think, is it Bianca who's been appointed now as head of R&D?
Yeah, she has been for a little while. She had, during this year, she was on maternity leave.
And I can see there's some stability around that now, this in there as well. So, yeah, thanks.
Thanks for those, Aled. Alison?
Ella, on driving up our commercial income, is the team structured to support commercial separately to non-commercial, or to say, should it be focused that way if it isn't? And my second question, sort of noting what noting what Kim put in the chat around the 4th year of intake of chief nurse research fellows. Should we have a workforce plan to, you know, perhaps working with Mary as well on clinical medical fellows too? Thank you.
Thanks, Alison. Do you want me to take those questions? Yeah. Okay, so in terms of the structure, I think it's something we need to look at, and I think that's something we need to probably make more clear. So I think, yes, there are some team members who do more of one than the other, but it would benefit from us aligning our intent around the strategy to making sure we've got the team set up in that way. And I'd really welcome that offer around workforce planning, Alison. I think it'd be really helpful with Mary to sit down and discuss that. And I think, again, just links back to my point really around we have an ambitious strategy. Finance and Performance Committee have asked us to do this, that kind of check back. Have we got the resource and are we set up to truly deliver on that ambition? That'd be really helpful. Thank you.
Thanks, Ella. Ian?
Yeah, and I think it's largely been covered probably in those comments, but it's just that bit around making sure that as we move into the next financial year, we're looking at what the opportunity is as this is part of our overall savings programme, because it's, you know, it's linked with our strategy in terms of university hospital status. So very happy, Ella, to continue the work that our teams do together in terms of what is the ambition and perhaps a buddy organisation who do this really effectively that we can learn from as part of that might be something we consider.
Yeah, thank you. Thanks, Ian. Mary and then Kim, and then perhaps that we'll stop there. So, Mary.
Just picking up on Alison's point about workforce planning for clinical medical fellows, I think it's going to have to become part of the language within the care groups when we're looking at hard to fill posts. How can we do things differently, innovative posts, hybrid posts? So it feeds not into the strategic direction of our research ambitions, but it's massively important in terms of how we're going to attract and retain staff here. So I think it just needs to become a thread in all our workforce planning conversations and our, you know, even as far as, you know, reducing agency spend, all our different threads pull together to look at that. So yeah, really important. Happy to sort of support that.
Great, thank you very much. Kim.
It fits in nicely there, Mary. Really happy to share. So it's a fundamental part of our non-medical recruitment and retention strategy, and we can see that coming through. So it's how you say we normalise that. So if we align both, it's absolutely fundamental for people to recognise, and it's widely adopted now. So happy to share and align.
That all sounds really, really positive. And just to end on another positive note, it was really nice to see the Good Values Initiative, which is now being replicated across the trust. So, you know, well done to that team. So that's great. Thank you. We're asked to note the annual report and perhaps also to note the offers of working across the piece in order to push that forward in a more strategic way. Thank you. So, well done, team. We are doing okay with timing. So I would like to propose that we stop for what is going to pretend itself to be lunch now, because we've only got 15 minutes. So I would like to stop now and come back, if we may, at 15:15. Oh, sorry, I forgot to say that. I'm jumping ahead of myself. Thank you. I know why you're here now. Sorry, we've got a joint safeguarding strategy vision, and it is a starred item, and we haven't had any questions about it. So well done, Lindsay. Thank you for that. So if we could...
Mary, sorry, Maury, could I just clarify? I just had one question come up on email. It's just to remind everyone that it was going to be a safeguarding strategy, but following consultation, quite rightly, it went to a vision, and it's live across both RCHT and CFT.
And it is live. Yeah, that's really helpful. Good. So if we could come back at just after 15:15, please. And when we come back, Kim, you're going to be standing in for Steve, who has to attend another meeting, but just for a short time. So thank you for everybody, and we'll see you at 17 minutes past, please. Okay, welcome back, everybody. Thank you for being so prompt in returning. And as I said before, Steve isn't missing. He's had to go to a different meeting. And Kim, thank you for deputising. So we come to item 12, our Finance and Performance Committee Assurance Report. And as I said earlier this morning, our committees do a great deal of work with these reports before they come forward. And so, Richard, if we could have your chair's report, please.
Thank you, Chair, and thank you, colleagues. I'll take the report as read and just recognise it's the report covering September and October. As ever, I'd ask the board to note the decisions taken on behalf of the board at Finance and Performance Committee, those that are being referred onto the board at different agendas with our recommendations, one of which is on today around the contracts over £1 million report, and also those items that we discuss and scrutinise for assurance. I think I'd like to point out from the report this month that there are several areas of partial assurance, and I think I wanted to stress to the board that that partial assurance is not a comment on the extensive work and the quality of work being undertaken by colleagues across the Trust, but it's a necessary assessment given the metrics in some of our areas, for example, our ongoing financial challenges and the metrics that one will see in the integrated performance report later on the agenda. So I just wanted to make that clarification around the assurance around our positioning versus the assurance around the plans and the implementation of those. I drew out the Chief Executive's report just applause for the successful opening of the St Austell Surgical Hub and noted at that point that we would recommend or propose that the board write to colleagues and those teams that have made that such a successful start. I think I'd also like to suggest the board note the extensive work being undertaken to ensure our go-live date for the eCare programme, which is now November 2025. There'll be a paper at the board in private later, but I just think the board would be wise to ensure it keeps in its vision the strategic impact of that programme of reform and transformation that will have such wide-ranging impact in the future. The board may also wish to note the additional scrutiny that's been provided at Finance and Performance Committee of our financial recovery and our cost improvement metrics, and our quest to ensure that we're not only hit our desired run rate for this year and for this point in the cycle, but also that we recover our position. And I think perhaps when Ian covers our month 6 reports, that might be a focus for the board in terms of the slowing of the run rate, bringing us back into line with our plan, but also the necessary work to recover from there. I think you'll note in the board there's only one escalation. I'm going to refer to it as, I guess, escalation light, because it's an ongoing request to the board, but it's really just for the board to think about how it can better provide the clarity and support the movement of resources to help deliver our workforce efficiencies programme. You'll see littered through the agenda today references to the workforce efficiencies programme in the strategic the report on our strategy to date in the biannual report. We'll note in the month 6 some of the vacancies that are being held as part of our recovery and also the wider workforce transformation programme. So it's really just for the board to keep the consideration on how we help colleagues move that support around and also provide the clarity for it. I'll leave it there for questions. Thank you.
Really helpful. Thank you. And again, as I said to Isabel, thank you so much for the work that your committee does. So we have a full report there from Richard. Are there questions on the chair's report of that committee? I think you've done too good a job there, Richard. It's obviously answered everybody's concern. I think we need to agree that we will send the letter of thanks about the St Austell Hub within the next couple of weeks. Is that okay, Lindsay, if we make a note of that? I think I had a question about eCare, but I think it probably is better later on. So I don't have any further questions. Anybody else have further? No? Okay, thank you. In that case, we do need to note the escalation of to the board of our ability to support colleagues across the trust to deliver the workforce efficiencies programme. And then if we could please note the report from September and October Finance and Performance Committees. And then if we could move on, please, to you, Ian, for our month 6 finance report. I think you're still muted, Ian, sorry.
Can you hear me now? Yeah.
Yes, we can. We just need to turn the
Just
volume
turn you up a bit.
Peter, I think.
How's that?
Perfect, thank you.
Excellent. So thank you, Chair. So yeah, I'll take the report as read. This report covers the first 6 months of the financial year now. So we're at the halfway point of the financial year, and you'll have noticed in the paper that it's a slightly different looking paper. So following discussion at the Finance and Performance Committee that you alluded to in terms of where a lot of this gets the challenge and discussion, we've redesigned it to be clearer and more concise in terms of the messaging. So we still have a lot of the detailed appendices that exist that we've reported normally in the report, and we're going to produce those on a quarterly basis to the Finance and Performance Committee. But I'd welcome any feedback from board members. I know it was well received at Finance and Performance Committee last week, so any feedback on it really welcomed. I'm going to summarise just in 3 areas then. So what's going well from the report? In month 6, you'll see that the Trust delivered an £840,000 actual surplus, and that was favourable to our plan by £900,000. This is the first month in this year that we've delivered in month better than plan, and it was also in line with our recovery trajectory in our financial recovery plan. So I think we just need to use that as a moment. You know, we've got the first month of the year where our actions have meant that we're within our budget that we set, and actually are in line with our recovery trajectory that we submitted to the ICB, the Integrated Care Board, and to NHS England. The overall Cornwall system position remains consistent with our reported position, so the other 2 organisations are on plan from a financial perspective, and our overall rating with NHSE is a level 3 for confidence in the delivery, with 4 being the highest level of concern, which triggers national intervention. And that's consistent with our month 5 position, and the informal feedback we've had is that once there's been several months of consistent delivery and recovery in line with the plan, that we'd look to move back towards a level 2 and an increasing confidence in that delivery. What else is going well is we saw a decrease in agency spend. You'll note in the report from 1.4 to 1.2 million. We need to note though that's still above the £1 million level in the plan, and we're just in the process of sharing a pack of our first 6 months of agency spend and trends, cut in a number of different ways to support care groups and the organisation more broadly in terms of what more we can do on that. We've seen a significant increase in CIP delivery in month and in the forecast following the focused sessions and that we've had with each of the care group and corporate teams led by Steve as Chief Exec. And at month 6, therefore, our year-to-date SIP delivery is on plan. We've also seen recurrent levels improving, but we need further work on that to ensure we get to the planned level of 60%. Currently, we're just over 41%. Elective recovery funding and the income associated with reducing our rates for elective patients, that continues to overperform against the year-to-date plan and forecast to in future. And I just wanted also, in terms of what's going well, is to thank our teams for the focus and the professionalism which they've continued to show in terms of approaching the financial challenges and getting to this point that I'm able to report today in terms of month 6. So that was what was going well. In terms of things we should be worried about, the year-to-date position, whilst it's improved as a result of the month 6, it still remains adverse from our plan by £3 million. And the forecast range without our mitigations would be anywhere up to a £13.3 million deficit. Our care groups, we still have several care groups forecasting to be material off plan by the end of the year, and that must improve to ensure that we achieve that break-even position. Within the paper, you'll see that the recovery plan, there's some details around the financial recovery plan and particularly the red risks within that. And there's going to be a common thread here in terms of some of the things we've already heard in the meeting. So specifically the ones to flag as concerns are our use of escalation capacity and temporary escalation spaces. That has a financial implication, and the actions that have been outlined earlier in the meeting are key to ensuring that we start to see not only the quality and patient benefits from that, but also the financial benefits that flow as a result of getting those things working smoothly and operating effectively. So in the financial recovery plan, we'd assumed a reduction in those areas of 50% in October. That hasn't been achieved, and 100% from November onwards. The reset week is likely to be at the end of November, so they won't achieve the mitigations expected, and we'll need to look to other options in terms of how we manage that risk. The other thing we should be concerned about is the pay award risk, which you'll see outlined in the paper. So this is the pay awards have all been paid in line with the announcements. So the first number of those were paid in the October payroll, and there's some further ones to follow in the November payroll. Since that initial position was assessed, we have had further clarification, and there continues to be clarification being sought, but we've had some more clarification on the uplifts that are going to be applied to our training and education income. We've also now been able to assess the actual payments that were made for most groups in October, and we now think that residual risk of the gap in funding versus cost of pay award is probably nearer 200,000, and that'll be confirmed once all the pay awards have been made at the end of November. So what actions are we currently taking? So the paper sets out the detail of the recovery actions and the delivery against plan on page 325 of 599. In month 6, you'll see that we overachieved that by £500,000, and that's linked to us receiving industrial action cost funding from Department of Health, which covered around about 50% of our costs. So not fully funded, and that's still an issue that is underlyingly within our £3 million adverse to plan. We're going to continue to review all of the options as part of the financial recovery plan approach, and we've recently received from NHS England some learnings from the interventions that have been taken with other systems. So we're working through that. That was received back end of last week, and we're working through that to see if there's any further opportunities in that we can learn from. We have a separate paper at our board in private later this afternoon regarding financial recovery and SIP as well. The other actions we've taken is that following the financial recovery chief exec-led meetings, we've established an intensive support programme, and 2 of our care groups, our peripheral sites and our general surgery and cancer areas, are entering that supportive programme to further seek opportunities to improve the financial position and the forecast in those 2 areas. And we continue to undertake full financial forecasts each month, as you would expect. It's already been touched on in terms of the actions around our escalation spaces. We've got the systems support and resource in the form of the company Kingsgate helping with that, and that's currently being finalised in terms of that change in model. And just to update the board as well, in terms of other actions, the cash support that had been previously agreed and supported by board back in August has now been transacted in the with the ICB and our system, and that was submitted yesterday in line with the expectations. So happy to take any questions. I'll pause at that, Chair.
Thank you very much, Ian. And just before we take questions, could I note that Steve has now returned, so Kim is no longer deputising for him, just to be formal about all of this. Thank you. Questions for Ian? Rob.
It's not a question, it's an acknowledgement of the amount of work that the care groups have done to change that financial position. I think it's fair to say we've seen some really good engagement from our colleagues on what hasn't been an easy set of meetings to get through, and options to put on the table and work through. So it's great, Ian, for you to be able to report the impact we're seeing actually in the numbers as a result of all that hard work. That's what I wanted to add, Mary.
Absolutely, thank you. If everybody else didn't have anyone, I just... Oh, God, sorry, Richard. Richard
Don't
Kane.
you worry. Thank you. Thanks, Mary. It's a really clear report, and I like the format of it all. I just wanted to note something on agency, because I didn't think we gave it sufficient regard when we had Ella's report, because it was really great to hear that we're not using off-panel agency, and that's been real focus point in driving down agency. And you mentioned, so I suppose my question is, do you think we've now seen a reduction over sufficient months to ensure that we've got this, or because the caveat, I'm just slightly worried if you get winter months, the agency is going to increase. And then you mentioned a toolkit, and I didn't quite hear you. Is that going to sort of capture what's worked in order to feed back to staff to continue down this path? So just want to hear a bit more of the plans for agency in the next few months.
Thanks,
Yeah,
Richard.
no problem. So if I make a start on that, and then Alison, I see your hand's gone up, so I'll bring you in as well. So in terms of the trend on agency, we've tended to see a bit of a fluctuation. So we have significantly seen a drop if we compare it to this time last year. And part of the pack we're producing is comparing it both across the first 6 months of this year, but also to last year, Richard, to show that demonstrable impact that our actions have had. And to recognise that and recognise the efforts of the teams and the care groups in achieving that. In terms of have we seen a sustained improvement, we haven't yet. We see a kind of an up and down element of trend on agency. So we saw a higher level in August and a reduction in September. I'm able to flag from the October numbers, because we're now on the 7th of November, that we've seen a further slight reduction in October, which is really pleasing. And so that's a good sign for me that we're starting to see consistently keeping at a lower level. But we do need to keep a really kind of close focus on that. In terms of the piece I talked about, and I think that was what you were referring to, Richard, in your question. NHS England have shared with all organisations some of their learnings from the interventions they've been doing nationally and regionally with other systems. So we're not in that territory, but it would be really useful for us to. So we're working through that individually, and then we're bringing it together for all three organisations in our system in Cornwall and Isles to understand if there's further opportunity in that we might not have fully been able to exploit. So that's what I was referring to in that, and we'll play that back through into both committee and board in the coming months.
Thank you very much, Ian. Alison?
Yes, just further from what Ian was saying, we haven't had any HCA agency. We've got no off-framework agency for nursing. Estates have done fantastically as well in reducing, compared to a year ago, all their agency spend. We know we've got more work to do on medical, which obviously looking forward to doing that work with Mary on now. However, the CDs are engaged. Jackie and the workforce efficiency team have been meeting with the CDs on a Wednesday morning. They've got a toolkit. Everybody knows what they need to do. We just need to dig in and keep going with this. Obviously, it's a fine balance around operational pressures, and also, you know, we saw that fluctuation in sickness in August and September, where we had high COVID and high flu rates affecting, and that's where we have to be really careful around not then backfilling with higher cost staff whilst we minimise agency spend. So it's all a balance, really.
Our teams for managing to do that hard work. So thank you for saying that. Kim?
I think it's also important to note at CFT we've exceeded our agency target for non-medical workforce, but what's held us back at RCHT is the escalation and the levels of escalation and having to staff those. So it is not down to a poor process. We've got a very defined process and a series of escalation, but this is about managing the additional capacity as well as some surges in sickness and absence, as Alison has pointed out.
Thank you. So I'd just like to add my comments, if I may, on I really like the format. Thank you, Ian and your team. I found it very much more accessible for the way my brain works, really, really helpful. And then a point I might have misunderstood on page 9 of 13. I'm sorry, I don't know what the whole number is. Point 4, and it also appears in Appendix 3. Is there anything more we can do to mitigate or represent to the right people the fact that we appear to have less opportunity and productivity improvement vis-a-vis our peers, unless I've read that wrongly? It was that point about where we started and where we are now and productivity.
Sorry, Mary, which page in the report is that?
It was page 9 of 13.
Perhaps I'd suggest we pick that up in the productivity paper.
Happy to do that. Yeah,
might be useful. Yeah,
happy to do that. Okay, thank you. Are there any further questions for Ian? No. So we're asked to note the September, which is month 6 financial position, which is a favourable position to plan in month, but is adverse to plan year to date. Note the current financial forecast outturn range and the key risks and mitigations that are set out in the report in delivering trust break-even plan. Include the new risk relating to pay awards and funding, and note that the trust continues to report an external forecast of break-even at this stage of the financial year based on the actions being taken. And perhaps I could add another, which is to send thanks to teams for the hard work that they're doing in making sure we can reach these targets. So, board, if you'd be happy to indicate in the chat, that'd be lovely. We'll go on to the capital report, please, Ian.
Yep, thank you. So I'll keep this one a bit shorter. So you'll see in the normal way, this is again the 6-month capital report, and we undertook a reprioritisation for both our internal funded CDL capital and our externally funded PDC schemes, and that was something we'd highlighted we'd be doing as part of our normal practice, consistent with previous years. So as a result of that, for our internally generated funding, that's resulted, you'll see in the paper, that results in us having just under £500,000 contingency pot. And at this stage, we've chosen to keep that as a specific pot of contingency rather than allocating it against specific schemes. And particular reason for that is around the uncertainty of the new hospital programme and the pause while the national review is taking place. The paper sets out how that will be used, and we'll be able to update in future reports on what steps we're taking with that. But recognising in the budget, it's now likely that it will be the new year before that review concludes and we get absolute clarity. So it may be that we need some of that internally generated capital to cover off that risk. In terms of the centrally funded, nationally funded schemes, you'll see that there's a proposed list of changes set out in 4.11 of the report, and the notable changes in that are around e-care and the Women's and Children's Hospital programme. So overall, the non-CDL programme will reduce by just under £7 million to 31.4, and it is possible that that will be lower again, depending again on the timing of the new hospitals national review scheme concluding. Specifically on that, we've included a section in section 6 of the report which talks about the risks of that, and that's being managed, as I've said, by the contingency from the reprioritisation. The final point, just to draw out, and then I'll happily open to questions, is around the work being done for the next year's capital programme. So in line with previous approach, we're aiming to bring this to board in January or February time to have approval of a capital programme before the start of the next financial year. You'll note from the report that the initial list of requests for capital investment next year totaled £62 million. That's likely to be around £43 million higher than the available funding. That's not inconsistent with the position we found ourselves in, unfortunately, in previous years, but it just highlights the scale of challenge we've got across both our physical estate or digital and high cost equipment infrastructure to make sure that we're able to keep everything functioning and working as we'd want it to support our patients and our staff in their jobs. So we're still awaiting any further details about next year's allocations, and following the budget announcements last week, we're expecting some national briefings in the coming weeks. And as soon as we've got a further update on that, obviously we'll include that in the report. But really at this stage, it's just to acknowledge that work has commenced, and the challenge into next year for the capital programme is going to be as significant as it was in previous years. So I'll stop at that and open for questions, Chair.
Ian? Richard S. and then Adrian.
I suppose it's obvious within the report, but perhaps just worth saying, board probably needs to just keep a close eye. Finance Performance Committee will do it on board's behalf, because we're holding back the mitigation, and if things don't fall into place in terms of Women and Children's Hospital, we will use the mitigation on other things. It's the time scale by which that mitigation and the funding could be released in order to deliver the things that are being held in the prioritisation. So it's just making sure we align the timing of the release of the money that's been held back by mitigation against the appropriate prioritisation. But it's business as usual for our executive. It will happen.
Thank you, Richard. And we can't second guess when we might have an answer about the review. I think perhaps the only second guessing we could do is it might take longer than we think. But yeah. So that's a helpful point. Thank you. Adrian.
Yeah, it's not really a question. It's just a comment that on Tuesday of this week, Robin, Gavin and myself did a bit of a health and safety walk around on site. And as part of that, I saw some of the remedial works that are going on as a tower, fire remedial works. And I just wanted to say that the areas that I saw, the quality of the work is really, really good.
Thank you. Really helpful to hear. Yeah. Sorry, Isabel. I need to look at that screen, not that one.
Sorry, I couldn't come off mute. I think probably Ian's not going to be able to answer the question, but I just wondered, given the information that Steve shared in his chief exec's report about the budget, and hearing the health minister talking about infrastructure, whether he had a view on the likelihood of any capital increase coming to us, whether that's likely to be ring-fenced around particular infrastructure issues, because as you pointed out, we've got a huge backlog issue around estates. Are we likely to receive any additional funding which isn't ring-fenced elsewhere? And I'm asking you to have a crystal ball, Ian. I appreciate you probably can't answer.
Yeah, I think that's essentially, Isabel, that's the detail I'm alluding to that will come out of both the national briefings and the allocation details when we get them. I think it's clear that the prioritisation around the schemes where RAC, the concrete issues, are a priority. It's also clear that there's a big focus on digital and on everybody having a full electronic patient record system. Of course, we're already on that journey with an approved business case and a scheme in train. So we're already on a good footing in that. I think the area we need to make strong representations for is on our backlog maintenance. We've had the 6th asset survey updated and we've got a full comprehensive understanding of that. There's a system-wide updated submission being done by the 22nd of this month in respect of future year requirements for that level of capital, and we are making sure that the full impact of all of that is in that. That will probably determine more the next spending round as opposed to the spring budget, the budget we've just had. But yeah, unfortunately at this point, I haven't got that crystal ball, but we can only do our best in terms of making the representations in terms of the information we've got, which I think is a good starting point for us to be in.
Thanks, Ian.
Builds on Ian's response and Isabel's question. I think it's a really helpful one. When we look at the detail that has been provided with the budget announcement with regards to capital, the majority of it will be allocated to other areas that may not be directly useful to us. So Ian's already mentioned the reinforced autoclaved aerated concrete prioritisation. So of the additional capital funding nationally, about £1 billion is allocated towards that, and to reduce the maintenance backlog across the NHS estate. So that reduction in maintenance backlog is a potential area of opportunity for us. There's a further 1.5 billion allocated primarily for new surgical hubs and diagnostic scanners. Now, clearly, we have just opened our new surgical hub at St Austell, but we do know as a board we've got a further priority to, with our intention to enable an additional operating theatre at St Michael's Hospital for our orthopaedic teams. So whether there's any potential for us to be bidding against new surgical hub funding for an additional theatre to enable that to happen, that could be an area of opportunity. The rest of the financial allocation indicatively around the additional capital budget looks like it's going to other parts of the NHS, expansion of GP surgeries, pandemic preparedness, health protection, mental health crisis centres and other areas. So not necessarily a huge opportunity, but in some of those areas that there could be an opportunity for us to be positioning a bid for some of that funding.
Where will that get taken forward, Steve?
So we don't have any of that clarity at the moment with the budget only having just been announced, but I think that's an action executive colleagues could take away, and we can ask Brian on behalf of the board to develop an outline proposition around any potential additional backlog maintenance funding. We're already looking at the detail of how an additional theatre could be enabled at St Michael's Hospital, so we can have that ready to go as a potential opportunity.
Thank you very much. Alison?
Yes, so sort of following on from this year, next year and the following year, I just wanted to put on everybody's radar, and I probably will mention it in a few meetings, because I think it's a concern to me and other CPOs that we start to build the infrastructure for the new HR system for the future. And when I say HR system, I mean a people system that's interfacing with other systems, because the Oracle ESR, which is over 30 years old, comes to the end of its natural life. So, you know, need in support in raising the fact that this is going to be probably the biggest IT system implementation across the NHS, and that we need to get ready and make sure that all our workforce people systems are fit for purpose when it migrates over, but having enough capital built into future plans. So I'm not talking about next year, I'm talking about the year after. So I just want to raise that to everybody's attention. Thank you.
Alison, and so how are we going to be sure that progresses in a timely manner? Where will those actions happen?
So I'm happy to pick that up, Chair. We will pick that up through our prioritisation process that we have. So our capital programme looks multi-years ahead, and we can make sure it's capturing that. I'll pick that up as an action to feed that back to my team to make sure it's incorporated.
That's lovely. Thank you very much. Steve, do you want to come back?
Yeah, just as a follow-up, I think it's a great challenge, Alison, and I think that's an example of the new Secretary of State's expectations of the NHS in terms of using digital technology to further transform productivity. So that's one of the three core planks of the Department of Health and Social Care's priorities. And as we've already mentioned, the productivity element that's part of this year's budget is probably preparing the way for a significant productivity expectation falling out the NHS's 10-year plan. So as well as capturing that individual component, Kelvin, with executive colleagues, I think being able to develop over a period of time what our broadest view of those digital transformation opportunities are to support improved productivity over the next 5 years, I think would be helpful, and could also be useful for us in terms of securing any capital funding that that might be necessary.
That's really helpful, thank you. Okay, so we're asked to note the financial position for the capital programme for the period to the 30th of September, and that we expect to operate within the capital departmental expenditure limit, to approve the reprioritisation of that CDEL monies, which will result in 0.455 million of contingency available to cover the risks associated with the Women's and Children's project fees and with the Strata IT system. Should those risks not materialise, Capital Approvals Group will reprioritise this funding or seek approval to do so, depending on the values involved. We're asked to approve the reprioritisation of the non-CDEL capital programme, which reduces the expected spend in year from 37.7 million to 31.4, noting that the actual spend may be lower on the Women's and Children's programme, depending on the timing and outcome of the National New Hospital Programme review. We're also asked to approve delegated authority that should the Trust not be able to move 2.4 of eCare funding into 25-26, the Chief Finance Officer can authorise that the purchase of the linear accelerator from April 24 to March 24, so that funding is not lost in year. To approve the 0.136 million funding to be received for the diabetic eye screening cameras, and to note the draft capital programme and the work being undertaken to prioritise ready for approval. So if people could please note that in the chat. And if we could move on, Ella, please, to 12.3, the productivity report.
Thank you. Okay, so I'm just going to set a bit of context again on this, because productivity is quite a complex topic, and I think just to recap a little bit is sometimes helpful. Productivity has been a real focus for the NHS, probably now for the last 12 months, and partly in response to how do we recover and get back on top of our very long wait. There's been lots of analysis nationally, regionally, and then also now within our own trust locally to look at what's driving the productivity changes since 1920, and most importantly, what we can do about them. So this paper, I think helpfully actually for the first time outlines the 4 key productivity tools that are available to us. They're available to us and they're available to all trusts and systems. And I think it's really helpful that the team have outlined those here. And we are already making use of these, but I think it's fair to say we will be doing so more proactively in coming months, and really translating those into, okay, what do the tools tell us and what does that mean we should be doing differently in the organisation to make the biggest impact. We also, I think, might be helpful if I explain, because there's 2 sets of references in here. We refer to our kind of local RCHT reporting on productivity, and we refer to our national position. And I think that can be quite confusing. I'll try and break that down for people a little bit, but essentially, nationally, they are reporting on productivity of all systems. And so in this pack, when it refers to Cornwall, it's referring to the whole system. However, uniquely for us, we are a system that only has 1 acute hospital, and productivity data is only driven by acute data at present. So essentially, we can refer to Cornwall system as Royal Cornwall Hospital's data nationally. We internally have also developed this year a productivity improvement plan aligned to our operational plan. Our model for that very, very closely aligns to the national model. It's as close as we can get it. The national team have even looked at how our team have done it and are really impressed with how close it is aligned. But there are some differences in terms of what activity is being captured and excluded. So it will never be exactly spot on, but it is very closely aligned. In terms of timing, the national position is 1 month behind us at present. Partly you can imagine that is they have to take all the information off all the trusts and collate that and churn it out through their model, whereas we can take our local data and turn that around much quickly. So in this report, we talk about our local RCHT position and we're reporting on month 5, whereas nationally we're talking about month 4. In terms of what's that's showing us then, so if I talk about the RCHT position to start with, we had a plan that said we would improve compared to our 1920 position to a reduced productivity position of minus 15.6. So all trusts nationally reduced since 1920, some more than others. And we actually were sticking out as quite an outlier, being at 19.6% reduction from 1920. We're now we said in our plan we would get that to 15.6 by month 5, and we actually achieved 15%. So we were better than we said we would be in terms of our comparison to 1920. However, we also measure and planned to improve compared to last year. And comparing to month 5 last year, we said we would be at a positive improvement of 5.6%, whereas we've actually achieved a 4.8% improvement. So we have improved, but not yet by the amount we said we would in plan. And when we drill down into that, essentially, we're doing more than we said we would on activity. So we're doing a greater level of activity, but we're not yet delivering the amount of cost improvement that we need to deliver. And I think that reconciles with everything we hear around our financial position, etc. Then if I move into what nationally we're saying at month 4, so officially we've only got, at the point of writing this report, we only had the month 4 position. In my inbox today, month 5 has landed, so I can make reference to that at one point in time. The month, in a moment. Month 4 was really significant for us because it showed us a really significant improvement in how we're benchmarking nationally. And we all got very excited by that. I can say we can still hold on to some of that excitement, but it may not be quite as good as we initially thought. Month 4, nationally said that we had jumped to being at only 13.5% adverse, which put us at 3rd best in the region and put us really on a par with the national average, which was fantastic news because previously, as I say, we'd been an outlier. And we knew that within that there'd been a change in month in how elective activity was being reported, and our local model, and this is the benefit of us having developed a local model, we could check and balance and say that seems out of kilter with our local position, because I said earlier we think it was a 15% improvement, whereas the national position was saying 13.5. The team now have done some work with the national team. They have recognised they slightly overstated that position, and at month 5 we are at, on nationally, 15.5%. So still more aligned with what we said we would be, actually, in terms of our local plan. So we're doing what we said we'd do in our local plan, puts us at 5th out of 7 in the region, and I haven't yet seen where that benchmarks us nationally. So I hope that kind of makes sense. I'll take a breath. And then I think what's really important as well in this report, it kind of moves us into the space of saying, well, what are we doing about it and what are the key focuses for us as a trust? And helpfully, some of the tools point to things we ought to be looking at. So the first action, as outlined in the report, has actually been concluded because it was around reconciling that local and national position as at month 4. The team have done that, and I'll be able to fully update in the next month's report on what that found. The second action relates to we're going to have a focus on our non-pay cost growth and targeting areas where we can see, using the tools, we're an outlier on some of our procurement elements, and our chief procurement officer is already engaging in that work with our care groups for us. The waterfall diagram also pulled out that we have a larger than some opportunity in our non-elective length of stay. We still actually benchmark relatively well on length of stay overall. However, our decline has been bigger than some in recent months. I think we can understand why that is. We know we have particular challenge in non-elective care, and I think a real opportunity with the reset coming up and the work we're doing with Kingsgate on flow to make an impact there. And then the fourth one is around our medical workforce cost growth. So again, some of the benchmarking tools point out we have an opportunity there to improve, and already through the workforce efficiency programme we've turned attentions to some of our medical staffing costs, but we'll continue to do that and continue to do so, particularly in areas where we can see we outlie. It's also worth us noting, which I think relates to the question you had earlier, Mary, around our, the teams have done some benchmarking around our overall cost profile. So as an organisation, and I think it's quite reassuring to hear, but the double edge of this is it gives us a bit of a challenge around cost reduction. So in the NHS, they measure cost per weighted average unit and something called the National Cost Collective Index. And essentially it's saying kind of, how expensive are you relative to what you're doing? So whilst we absolutely agree and concur around the reduction since 1920, and we have that desire to improve upon it, we actually consistently are in the lower quartile in terms of both those measures. So we need to drill into that more and really understand what that means, because I don't think we can just say, okay, that means we don't have opportunity to improve. I think we need to get a bit more clever on that and really understand, in which areas are we in lower quartile? Are there some areas we're still more expensive, and understand the nuances in there? So that's going to be an area of focus for us as well. And I think we're really starting to mature in our approach on productivity. So I'm hoping that comes across in the report. I know it is still quite a complicated report to read, and we'll do work on making that more digestible for people. But I think also we're starting to really see through the intensive support programme we've got for some of our care groups, through the work we've been doing with those chief executive-led reviews, productivity is starting to become a language people understand more now and are using and seeing the opportunity in terms of how we can drive efficiency through the organisation. So I think it's been a positive and a lot of work from a multidisciplinary team to get us to the place where we understand it much better now.
Thank you. Well done. That is a complicated report to talk to, and I really appreciate you taking us through that. I've got immediately some hands up. I've got Kim first.
I can't believe I beat Isabel that time round. Absolutely, thank you for the report, Ella. Can I ask, and I know Steve's CEO report mentioned it, we are being asked how we're going to quantify how we're using the new NHS Impact Clinical and Operational Learning Guides, and I think this area of work absolutely fits in with those four, doesn't it? At the OPD, outpatient services, theatres, surgery, peri-op care, of course, medical consultants, job planning is, I think, would be a really good opportunity to be able to bring those in.
Yeah, actually, I really agree with that, Kim. So some of those have a really clear productivity angle on them as well as quality. So I think we should overlap those and add them to these toolkits. There is a lot of help and support out there now. Lots of toolkits being developed nationally. It's just how do we enable our teams to access them and find the ones that are most useful for them. But yeah, thank you. That's a useful link across.
Thank you.
Thanks, Kim. Rob?
Thank you. So the eagle-eyed will have noticed at the beginning of today, we talked about our length of stay reducing, and in the integrated performance report, you'll see that that's a very good number. Ella specifically talked about non-elective length of stay. So for members of the public, that's generally speaking, that's patients who'd come through the emergency department. And so our surgical length of stay is very good. And that's what drives our overall trust position, which is the IPR. Our non-elective, as mentioned, is an area where we know we have opportunity to do more. And what we did in our operational leadership group meeting only yesterday, when we reviewed this report in detail, is we talked about the fact that doing the right things by our patients will drive our productivity. So we really laboured on there's a quality benefit to our patients to making our non-elective length of stay as short as it reasonably should be. And in doing that, we will therefore drive our productivity indicators. So trying to make it that this isn't a finance report, this isn't a productivity report, this is the output of us doing the right thing. So I think culturally that's really important for colleagues around this table to hear that's our operationally, that's our approach to the information this report gives us.
That's a really important point to make. Thank you. Gosh, you were slow this time then, Isabel. You're next.
I know. As the day goes on, I'll get slower. I apologise. Rob's almost kind of addressed the point I was going to raise, really, which, Ella, thank you. And thank you for going through the report in the way that you did, because there's a huge amount to kind of digest within it. And we're all starting to learn more about productivity as we go. For me, the two measures at the moment, one's around activity and the other's around cost. But I think I've just heard Robin say that actually what drives productivity comes from a place of quality. And as chair of the quality committee, what I would like to see if there's a way of integrating the report that you're producing around productivity focused around cost and activity, but also taking into account the quality thinking and also the quality impact of productivity gain?
Yeah, I think we can. And I think as we start to pull out what it is we're doing to change things here, because I think up until now we've been very focused on explaining why we are where we are, whereas we're moving into a space of saying, and what changes are we going to make that will have an impact on productivity. Clearly, we'll only make those changes if they're the right thing to do. So I think we can move to a place where we'll start to see what quality metrics will change, so such as length of stay, such as access to services, outpatient efficiency, things like that. And I'll endeavour to pull those into this report as they start to make an impact.
Thank you very much, Ella.
Thank you. Alison?
Yeah, Ella, this really helpful report. Really good to see the comparators. However, I still have some questions on some of the workforce metrics to make sure that we have got apples being compared with apples. And so I'd like us to know, for example, on the on the bank figures, are we comparing all trusts? Because some trusts, like ourselves, have an in-house bank. Other trusts have outsourced banks and are not included in their workforce figures. Also, on turnover, I'm aware of inconsistencies of reporting at national level. So, for example, internal movement, somebody moving from one department to another department, is not real turnover. So again, I just want to make sure in the data that we are capturing what is accurate data. The other point is around those trusts that have higher number of intake of resident doctors for training will be adversely impacted by turnover. And I'm glad you've picked up the point around language as well, Ella, because I think it's really important that our staff are now sort of starting to understand this and embrace this, because it isn't about cuts, it is about doing more with less. And I think we're starting to really understand that. So thank you for picking up about the language point.
Well said, Alison. Thank you for that. I'm not going to take any more speakers after Ian. So tough on people who haven't put their hands up yet. Richard.
So I thought it was going to be the last one, and that was it. Adam and me, good night. But thank you.
You and Adam, and then Ian.
Yeah, thank you very much. Thank you, Ella, because I read the document twice and kind of got it, and then when you explained it, I got it completely. So, my question, I suppose, is based slightly with frustration about how these metrics are set. So bear with me, because we've heard a lot of words around activity, cost, quality, and efficiency. I think to translate this locally, what's missing for me in terms of productivity is a happy workforce that want to be there, that are supported. And none of that is covered in these national metrics. So I think it's just really important that we link it to our local plans. We also link it to Alison's work. So we're thinking about how we can listen to staff to improve and how we can support their well-being. How can we develop a management culture that is focused on improvement, but how we can actually have a better investment in our workforce to ensure that they have the skills, because all of that tells me productivity, and none of that is in the national metrics. So I suppose my plea is, can we try and do something locally, at least aligning Alison's important work over here with productivity that we're looking at through this lens.
Thank you, really helpful. It is acknowledged, I think, nationally, that morale, well-being, all those things play into productivity, but it is in that space of less easy to measure. These are the things we can measure, really, more concisely. But I think it's really important. So we do need to find a way to focus in on it here. I don't think we'll make the impact we need to make as the NHS wide without addressing those things as well.
Thank you. Helpful point, Richard. Thank you very much. Adam.
Thank you. I'm probably going to echo, but say in a completely different way, what others have said. I'm not like Richard Kay, I won't pretend I fully understand this, but thank you to Ella for the presentation. That's now the closest I'm coming to understanding the productivity information we're wrestling with, so it's really helpful. Thank you. So just a few thoughts would be, I think over time this report would be really helpful if it could home in on headline messages. And I worry that we're getting lost in a lot of information that comes to committees and boards. I think the critical thing we want to see at committees and board, from my perspective, would be the triangulation of 4 things, if that makes sense. The productivity, the performance, the finance and the people, and how we can demonstrate those 4 things are zinging together. And what I'm particularly keen on us seeing, which we talked about in the Finance Committee, is what productivity improvement we're expecting from our savings programmes, and how our productivity issues should be driving our future savings programmes or our future investments. And then I can really see the whole thing zinging. And that's a big ask, but it was really helpful what you said. That's helped me get my head around it a bit. So thank you.
Thank you very much, Adam. Ian.
Yeah, thank you. I just wanted to build on Isabel's point in terms of quality. So I think we need to be careful as well, just to make sure that we use this as one of several metrics that we look at as a board. So 2 very, very snappy examples. If we achieve our ambition of not using our escalation spaces, that will reduce our cost and it will improve quality and it will improve productivity. A different example, if we invest as we need to in the neonatal workforce around our standards and CNST compliance, that won't necessarily deliver us more activity as an output, but it will increase our quality. And we know that our maternity services are rated as good, and previously they weren't in that place. So there will be some instances where a change in our cost base will deteriorate productivity but improve quality, and there will be others where it's a byproduct of improving quality improves productivity. And I think just being attuned to that as a board is really important.
Thank you. Thank you for that. So we're asked then to note the current productivity tools, note the published productivity position as at month 4 and the internal forecast productivity, note the proposed actions against utilising data from each tool. And I'd like to just add one, which is to note that Ella has taken really careful notice of the points that have been made, particularly vis-a-vis quality, and that you will be incorporating that as best you can.
Yeah, thank you.
Thank
Really
you
appreciate it.
very much. Thank you. Brilliant. So that was a good discussion, but we lost the 15 minutes that we'd gained. So clearly we are paying good attention to what we're doing. So let's all just keep ourselves going, please. And that brings us to you, Adam, please. Item 13, People and Culture Assurance Report from you.
Okay, thank you, Mary. I'll do a few headline messages and then very happy to take questions, as I'm sure Alison is as well. And firstly, recognising that whilst people and culture is obviously a cross-cutting issue that we're all very bought into, I need to give a special thanks to Alison and the people team for all their work that comes to the People and Culture Committee, and more importantly, all the work supporting the organisation. The report you've got in front of you summarises and presents to you for assurance the September meeting of the People and Culture Committee, which was a particularly packed agenda. So we were unable to cover all the items, but the report is clear which items we had to defer to the next meeting. And one of the items we had to defer was actually a paper on how we can look at the structure of the meeting to make it easier to get through the agenda. But anyway, we'll pick that up at the next meeting. To highlight some critical points for us for today, there were 3 annual reports that we carefully considered at the meeting that are on our agenda today that we took full assurance on, which is the Medical Education Annual Report, and then 2 starred items on our agenda today, which is the Medical Appraisal and Revalidation Annual Report and the Clinical Non-Medical Education Annual Report. 2 items I need to bring to the board's attention where we took limited assurance, one of which has been talked about quite a lot in this meeting already, is around organisational development. And whilst recognising we're doing a lot of really good work around organisational development, and it's clear that everybody sees that as important, we did have, I guess, an ongoing concern about a lack of progress, lack of clarity about future phases. We could see where we were for 24, 25, but an uncertainty beyond that, and recognising that organisational development is a really important issue for us into the medium term is the first issue to bring to our attention as a board. And then the second one is occupational health. And again, recognising that colleagues in the team are working really hard, but it is an under-resourced service, which we have recognised to the point where we've developed a plan to address those issues, but we're concerned that there is a lack of action in addressing the issues in that plan and addressing that plan. And we've got the severe financial constraints on the organisation, which we completely recognise, but there's an ongoing challenge with the quality of that service. And we all know how important our workforce is and supporting our workforce. So that's the second issue I wanted to bring to the board's attention. And I'll probably stop there, Chair, and happy to take any questions.
Thank you, Adam, and thank you very much for your report. I do have a couple of questions that you've touched on, but colleagues, are there other questions for Adam? Okay, can I just pick up then the one on the occupational health plan? What further support could the board provide so that could be progressed? Because it has been an outstanding issue for some time, and we say we really value our workforce, but then that maybe suggests that we don't value as much as we should. So I wonder what else you or the committee would want the board to do on that. So that's on that one. And then the one on the organisation development plan. And it's really pleasing to hear what the committee is saying about the importance of this plan. And again, I guess it's a similar question, is there anything more the board can do to help with the issues and the challenges that are being faced in implementing that at a different pace?
I think that's from my perspective, and Alison might want to speak as well. There's a real issue here around both issues arguably require additional resource and are potentially in the considerations of the executive having about business. I'm not totally up to speed on where those considerations are at. But as I've said, we completely recognise the financial constraints the trust is under, but probably both those issues require additional resource.
Okay, thank you. Alison, do you want to go first? Because particularly on that point, and I'll come to you, Kim.
Yeah, I think Adam is right. They're both very little teams. So the OD, the EDI team is a very little team that is facilitating the OD plan across the trust. And as we commented on earlier, gaining really excellent feedback, but probably needs more resource. And what I would have hoped to have done had we not had the pressures would have been to engage more care groups in helping to facilitate those programs. So that I think is slightly different to what has happened in occupational health. Agreeing it was a small team to begin with that was delivering multiple contracts. I think it's slightly more complicated because we've had staff retire, we lost all our medical colleagues, and we look to additional support to a trust in Devon who were not able to support us. And so we've got a GP who's in training, who's now being supervised by a temporary resource in terms of that medical cover. But really what we want to do is build the plan for OH in line with the occupational health review that was concluded last year. And so it goes back then to investment and being another fragile service. But but slightly different, because I think with OH, we've got a national shortage of skill sets, not just a local problem.
That's really helpful, Alison. Thank you for that. Kim?
It sort of fits in nicely. I think we've got a real dichotomy here, haven't we? We've got occupational health. As Alison says, we did a full service review and we've still got many of the actions outstanding, but noting the increase in freedom to speak up that's come out of that unit as well, the tremendous pressures on staff that need occupational health referral, and then the connection between EDI and OD and some of this. I do wonder if we're at the case now, Alison, that actually this service, I know we've got the 7 high-risk business cases, but I think with everything that's been outlined at the last pod, and what, you know, with the question, what more can we do as a board? I do think this, as loath as I am to increase the high risk list, I do think this one tips into that area now, considering the challenges we have for winter and the impact that's going to have on staff health and well-being, and the continued fragility of the service.
Kim, I'll come back on what you said in a second. Ella?
Yes, I think I was referring mainly to the OD programme, but I think it is an example of where we need to give thought to how are we going to invest in the things we really need to do. It links for me back to the conversation we just had on productivity, where we all acknowledged it's wider than the numbers. It's around how our staff are working, how they're feeling, how supported they are. And I think we know that high functioning, effective teams are really helpful for reducing stress levels, for example. We know that reduced stress means fewer people are off work. But I just wonder if we need to really give some careful thought to how do we develop a case for investment. There will be evidence out there around where good, effective OD programmes mean that you are a more effective organisation, both from a quality and from a financial perspective. And I think we need to really think about that for the next planning round and be kind of sure that for each of our pillars of our strategy comes back to, are we resourcing and are we putting our efforts into the right place?
Thanks, Ella, that's helpful. Steve?
Just briefly to comment, I think, Alison, that those options are set out in a paper which is coming to the executive leadership team and coming to People and Culture Committee. So I think what we've heard is strong support from board members for a resolution and expansion, potential investment in these areas. So just to check with you, Alison, that we have a number of options for consideration that will come through in that paper.
Yes, that's right, Steve. We are considering everything because we really recognise the fragility of the service at the moment.
Okay, so thank you for that discussion. I think there is broad agreement round the table. This really is vital, and my heart goes out to you, Kim, when you say I hate to suggest another one, but this is the way we deliver our work, is through our people. And yes, Ella, there is a lot of evidence out there about how this kind of programme does benefit across the board. So I think unless anyone wants to disagree, then we would, Steve, encourage as a board that the executive leadership team looks at that in the light of what's been said today.
Well, I think that's really helpful. Just to note, I think Ian's made a comment in the chat about this, which isn't in any way contradicting what's just been said, but also putting quite rightly a challenge in that as part of this process, we should, in parallel, be testing what previous investments have been made, and if they haven't given us the impact that we expect, do those previous investments become a funding source potentially for investment, or is an outright investment needed? So just to note that we would expect that that challenge and rigour as well.
I think that's a really good point. And I think some of the other evidence, clearly not in this trust, but in other places, there is that evidence. And what we've said before about other mitigation and actions we've taken, we do need to measure. We did talk about that, didn't we, about the leadership aspect of the development programme, and we did have some positive responses, but it's right that it should be taken into consideration. So thank you very much for that. Could we please then note the Chair's report from the July 24 meeting of the People and Culture Committee, and note that our executive team is going to review that paper as discussed. And then if I could welcome Lawrence Moulton to the meeting and apologise sincerely for keeping you waiting. I am sorry that we are a little bit behind, and ask you if you'd be kind enough to present your medical education annual report, please.
Thank you very much for inviting me, and I'll try and be brief to not make you run over too much more. So medical education in the Trust is key in the developing of our doctors in training to develop their skills towards progressing in their training. The key thing that I'm really pleased about, and I've highlighted most within the report, is the main piece of feedback we get is the GMC National Training Survey. And if you look over the years, we had a large decrease in 2022, which is in the post-COVID period, where there was lots of things with workload and pressures and so on and so forth. But over the last 2 years, and particularly in the last year, we've increased, but in all but 2 of the metrics that the GMC survey measure. Of note, I've compared our scores, because they're all publicly available, to the other acute trusts in both Devon and Cornwall and the South West, and we're rated 1 for the quality of the educational supervision that we give to our trainees in Devon and Cornwall, and 2 overall in the whole of the South West NHS South West region. And again, we're very highly rated for reporting systems, both number 1 in Devon and Cornwall and number 3 in the South West, and that's really a testament to the work that we do within the Trust. The converse to that is the doctors in training are happy and their scores are increasing, but the trainer survey, which looks at the how the consultants and the other trainers that we have in the Trust, their scores have been decreasing, feeling that there is a level of them not feeling supported to provide that training, despite the good quality training that they are providing. There are 2 other things of excellence I'd like to highlight. The first is that the Obstetrics and Gynecology Department has been ranked amongst the top 10 units to train in the whole country for obstetrics and gynecology training, and that's based on feedback directly to the Royal College of Obstetrics and Gynecology from the doctors themselves. And they've actually managed that 2 years in a row, so it's a real credit to the team in the obstetrics and gynecology unit about the quality of the training of those doctors within Cornwall. We've also done quite a lot of work on introducing new international medical graduates into the Trust. So these are doctors who have trained overseas and often come to us, and it's their first job in the UK and their first job in the NHS. And whilst the medicine's the same, the systems are very different. And it's well recognised that these people need additional support to ensure a soft landing and to improve how they start and understand the NHS functioning. And we've put in a specific IMG induction. It's now on its 2nd year, and we won a national award for that innovation as well. There is data in about bullying, harassment and sexual safety, which is in the report. Now, the data that we have is not out with the national average data reported in the GMC survey, but we are taking it very seriously, even though we are roughly where the trusts are. So we are integrating further with the Freedom to Speak Up team. We're developing a regular triangulation meeting with ourselves, the Guardian of Safe Work, and the Freedom to Speak Up team, so we can identify problem areas and deal with them better. We signed up to the Safe Learning Environment Charter, and there's a sexual behaviours charter as well. So although our data is roughly where the national average is, we're taking it seriously, and we want to improve it and get it even lower, because we feel that any level is too high. I think I'll stop at that point and leave it open to questions.
Thank you, Lawrence. That's really helpful. And it was a really good and informative report. I appreciated it. And well done, because you picked up some of the questions that I had. So perhaps, colleagues, are there questions for Lawrence on this report? Goodness, you've obviously satisfied everybody, Lawrence. It's good to hear about the crossover with Freedom to Speak Up. I just want also to be, to really echo what you've said about the taking the bullying and harassment and lack of sexual safety very seriously. It's really good to hear you saying that. Thank you. Ella.
Yeah, I just wanted to acknowledge and I suppose pass on the thanks and praise for this team who are ranking us so highly in the training. It's fantastic to see, and for the Obs and Gynae team to be in the top 10 nationally, that's really significant. And then again regionally, and for me it just kind of adds to the excitement of why we are doing what we're doing and pursuing the clinical academic strategy, and why we're working closer and closer with University of Exeter, University of Plymouth, and why this is so important, because we can deliver really fantastic results and it makes a big difference to our workforce and makes a big difference therefore to the patients we serve. I think it's really great to see those successes.
Thank you, Ella. Rob?
Thanks, Lawrence. And that's a very positive report. Is there anything that we or I can reach out to help you with in any areas that you'd want to see us be able to do more improvement?
So I think the biggest challenges that we have, if you look at the GMC data, and the biggest things we get is, and some of this is our geographic location, it's the ability for people to get to their regional teaching, to access study leave, to access going to places, and rota design. Now those have improved, but particularly if you look at regional teaching, we rate bottom in the southwest. Now some of that is our geography, but it's about that balance between understanding that both trainers and trainees, whilst we all want to deliver that clinical service to everyone, it's about making time for that training whilst they're with us, and understanding that if we give people that excellent training whilst they're here, they're more likely to want to stay here and be colleagues in the long term and become consultants in the uni.
Thanks, Lawrence.
Thanks, Rob. Steve?
Yeah, thank you. Two things, Lawrence. Firstly, I know you said it, but I think as a trust board, we should acknowledge the really outstanding results from the GMC survey, the Obs and Gynae performance, and the example you gave of the National Award for IMG induction. That they're outstanding reflections of a great service, and collectively, I think, a really significant set of achievements. So if we could perhaps ask you to pass on our thanks to everyone involved. And also acknowledge your personal leadership in enabling this to happen. So that's the first thing. Thank you for that. The second one's a question on bullying, harassment and sexual safety. I think you've indicated in the report this is a challenge across the country, and we're not necessarily out with that kind of national position. But is there anything you think we as a board can do more to support eliminating bullying, harassment and sexual safety, and anything you'd like us to consider to support you and colleagues across our trust?
I think this is challenging because we have a lot of things that we're doing for it, and I know that when it does get reported, it's dealt with in the way it should be. The challenge I have, and the reason why we're trying to link up with the Freedom to Speak Up team and have more meetings to triangulate, is how we encourage even more psychological safety for people to speak up and report it. Because I know when people do speak up and they do report it, it's dealt with really well, but it's about how we encourage people to do that. And it's something that I've thought about a lot, and I don't think I have a good solution to, but I think it's about getting people to come forward and how we can encourage that even more than we already are, because I know that when they do, it's dealt with really well by the systems we have in place.
One of the things we heard earlier this morning, Lawrence, is that at the moment we don't have any Freedom Speak Up champions who are doctors, and Mary's already undertaken to try to work on that with yourself and others, and that may make a difference. I think it certainly has in our globally trained nurses. Having some champions from that group has made a difference. So thank you for that. Mary.
Mary, you somewhat stole my thunder. Oh, sorry. That's fine. I've got a couple of things. The first thing is, again, to pull out the success of the Obs and Gynae training team, and we ought to feedback, how impressed, and our thanks for that. I wrote down that I wanted to maybe link up with you to discuss how we can continue to promote doctors accessing the freedom to speak up avenue for raising concerns. We had a presentation earlier which showed that there's been huge inroads into progressing that, and in a way that other trusts haven't yet achieved, and the doctors are accessing that service. But as Marie points out, we don't have champions from the medical workforce. Now, I recognise there are problems with churn, rotations, etc. But I would be very keen to not only engage champions on at a consultant level, but actually to make sure that we've got champions through the resident doctor trainee levels as well, because I think they're close to the ground and they're potentially likely to be felt to be far more accessible within their peer groups. So if we can link in to try and work out how we can do that, and then more generally around the bullying, harassment, sexual safety agenda, really happy to sit down with you and see if we can work out other ways of helping to address that. And certainly previously where I've worked, we've used the GMC in some of the offers that they have around education and support to help with that. And that might be something, if we're not already doing it, that we could think about doing.
Thank you. Thank you very much, Mary. That's really helpful input. Richard.
I might have missed this. This is also on sexual safety. I was under the impression there was new requirements in the Worker Protection Act to have mandatory training around sexual harassment and clearer policies and procedures. So are we implementing those requirements when we're looking at this area?
Kim, you're nodding. Do you want to respond? Yeah.
Just come into effect.
No, that's really important. So there's an updated paper coming through People and Culture Committee, as well as Quality Part 2 Committee, on all of the updates, the work that's going across the training, the education, our communication. So that will all be rolling out now, and it's all in line with the recent guidance and policy that has just been, Richard, as you know, just been done. So you'll see that rolling out. I think it fits nicely into there. So we've recently had our regional meeting that I was on with Lawrence and other members. I think it isn't just about the triangulation with freedom to speak up. Actually, we've had stronger medical reporting through safeguarding, which is really the severe end of when things have really let down. So we'll do that triangulation with freedom to speak up, safeguarding, and Mary, really happy to link up with you. Alistair and I had spoken. We were going to hold an NMC event as regards professional practice, how you report with our NMC colleagues, but that got cancelled. I'd like to see that joint with NMC and GMC. How do we bring that together and make it more inclusive, but not discounting that it isn't just clinical staff, but I think that would be a good way of approaching this. And then we've got some really brave and courageous medical and non-medical staff in safeguarding that I think we are quite prepared to be champions and talk of their experiences. So how do we harness the power of experience as well as is very important.
Thank you very much, Kim. Thank you. Aled.
I just wanted to acknowledge the expansion and redistribution of training posts, page 15, in as much as there's a 60% increase in F1s within RCHT over the last few years. And that's just understanding how placements work and quality of placements. That's a significant additional capacity need there, and just ensuring that mechanism, because I see you flagging up that this is likely to increase now with the COVID bulge, which is coming through in the next year or two, as it's called, and also just redistribution of doctors from over-doctored areas nationally into rural and coastal areas, for example. So great opportunities, massive amounts of threats as well, I guess, within that, and the mechanism for us in people and culture probably, or somewhere to pick that up in terms of ensuring the training opportunities there, the quality is there, etc. But it's a double-edged sword, I guess, isn't it? It's really good news in many, many ways, but it's also a significant challenge.
Thank you. Thanks, Aled. Lawrence, you want to come back?
Yeah, I was just going to say on that, it's a really good opportunity for us to get more doctors in training. A doctor in training comes with 50% of their base salary, so not their out of hours covered. So it's a cost saving for the trust, and you're not having to run the recruitment process because they're all recruited centrally. So there are cost benefits, but you know, and I'm very indebted to Ian and the team and Jill, because we were asked to find, you may or may not know, there are a number of first year doctors who they recruited more than there were posts for, so we were asked to find 6 additional posts at 2 months notice for an August start, and a lot of work went through. And that's the challenge of, you've got one part of NHS England saying, here, there's more doctors, we'd love you to employ them, and another half of NHSE saying, don't increase the number of people you're employing or spend any more money. And it's that balance, and I'm sure Ian's probably got something to say about it, because whenever these come through, I always email him going, we've got these opportunities, and it's a real opportunity, but equally it's very challenging when we're in a financially constrained position to find posts for them. And sometimes we can switch a trust doctor to a doctor in training, but again, that's not always possible. And it's always at a really short notice. So we had an email, I think 2 weeks ago, offering us, do we want to bid for more? And the closing date is next Friday, and people have got to put all their plans in place for us to bid for doctors at a 4-week window. So one of the things I've got to do this afternoon is chase everyone up and say, do you want us to bid for more or not?
Thanks, Lawrence. Ian, I don't know if you wanted to comment at all briefly.
No, I think Lawrence has covered it off really well there. It is the kind of the challenge that we've got, really. But you know, Lawrence is really helpful, as are other colleagues, in terms of looking at those solutions. And I think it's how we use that as an opportunity in the way that Lawrence has just eloquently described.
Okay, thank you. So, Lawrence, please hear our thanks for the work that you do and for the work that other teams do in getting the kind of results which are really great that we're getting. Thank you for being open and honest about the things that need to be worked on further. And thank you to Mary and Kim and others for their offers to work with you in kind of taking this forward. Perhaps if the board would be good enough to note the contents of the medical education annual report 23-24, and also pass on our thanks to the team for the work that they do. And Lawrence, thank you for being with us. I'm sorry we delayed you.
No, not at all. Thank you very much.
Okay, thank you. So, colleagues, 13.2 is a starred item, and I haven't had anybody raise any questions, so we're asked just to note the report and that the Trust met the standards required to be able to submit a statement of compliance to NHS England. Also, as recommended by People and Culture Committee, to approve the statement of compliance, which is at Appendix 1. On 13.3, similarly a starred item, and I haven't had any questions raised. So we are asked to note the annual report on non-medical education. And note the assurance on the provision of education as a means of supporting service and workforce development. And we're also asked under 13.4, which is another starred item, to receive and note the update on flu and COVID vaccination report. So if you'd be kind enough to note that in the chat. And while you do, if Isabel could give us the Remuneration and Appointments Committee assurance report, we will be a bit closer to having a break.
Thank you, Mary, and I will keep this really brief because this committee considers items that don't then come in full to the public board or to the private board due to the nature of the issues that we consider as a committee. You'll see from the paper there are a few bullet points just to share with you. We received at our last meeting an update on our executive director and very senior management recruitment and opportunities, and delighted to welcome our new chief medical officer, our chief finance officer, and more recently again our director of nursing, midwifery and AHP. So that's all underway and hopefully in situ now. We did receive and note the annual review of the very senior management contracts, and we also noted the current executive director succession plan, just to make sure that we're on track with thinking about our succession. And then the final point really that I wanted to raise was that we are we approved a continuation of arrangements for toil, time off in lieu, for our executive colleagues through to the end of March of this year. But we are concerned that we begin to think about how we develop an exit strategy around that, and are very mindful of the need for our executive colleagues to be able to take the breaks that they are due and not to be at working excessive hours and on call. So that was quite a lengthy topic of conversation. And finally, we received assurance around the Trust's fit and proper persons policy and approved that policy. So I think that summarises our latest adventures with the Remunerations Committee. Thank you.
Thank you very much, Isabel, and for the work that you do in chairing that committee. Are there any further comments on that at all? No. Okay, thank you for that, everybody. We are asked to note that Remuneration Appointments Committee report from its August 24 meetings and the decisions taken on the behalf of the board. And it is 13:49. We now have a 10-minute break, but we could come back at 2 o'clock. So you can have 11 minutes then, but we will need to come back.
I could have taken another minute.
Credit to you, Isabel, credit to you. Lovely. Thank you very much for being back in a timely manner. And well done, everybody. We have got another break coming up in a little while. And yet we've got some very important work still to do. And also thank you to members of the public who are sticking with us. We really value your questions and your feedback. So we're now on item 15, which is our Charitable Funds Assurance Committee report. And we are considering this item in our capacity as corporate trustee rather than as board member. And Richard Crammer kindly took over the chair of this committee not long after he joined us. And I'm pleased if I could ask you to present your report, Richard.
Great, thank you very much, Mary. I'm just mainly going to focus on the...
We can't hear you at the moment.
Okay.
Try again.
Hello.
Yeah, got you.
Brilliant. Thank you very much. Thumbs up from everyone. I'm mainly going to concentrate on the family accommodation unit because that's taken up most of our discussions. And we've had 2 meetings since we met. The committee has reaffirmed its commitment to the family accommodation appeal, and we noted that 1 million has already been received. We had an extraordinary meeting with a view to agree a preferred option to go to the board today. The preferred option is a refurb of Ben Rupen House, but scaled back. So we've scaled back the remit and cost of the project. So it will support 7 families rather than 12 at a lower cost of circa 1.8 million, which does not include the fundraising costs estimated to be 800,000. And in addition, there would be additional costs involved in moving the executive team out to make that family accommodation ready. Whilst this is the preferred option, we agree that further work is needed to finalise the capital costs and associate risks, with timescales for start and completion, and the fundraising plans to support the appeal. We also agree that if the finalised capital costs are too prohibitive, we could look at the fallback second option, which is accommodation outside the NHS site, a few minutes away from the main site. So we didn't think we could. We haven't been able to finalise these outstanding points in time for today, but we propose to come back to the board in December to sign off the final plans.
Thank you very much. Thank you, Richard. I don't know, Alison, if you wanted to comment any further as Richard's summarised it.
Yes, I think Richard summarised the main focus for the Charitable Funds Committee. Obviously, there is a lot of good other work going on, which I also want to sort of pay tribute to. Most recently, obviously, the cycle pedal for patients. Thank you.
Wish your husband was a participant, Alison. Thank you.
Yes, he was.
Thank you.
All for the minute.
Thank you very much for that. Okay, colleagues, I have a couple of points, but are there other points for Richard on this topic? Adrian? No?
No, I was at both meetings.
Ah, okay. So if there aren't, or perhaps while people are thinking, I suppose I'm just I am bothered about the pace of this. We have said for quite a time now that we want to do it, and it's an absolutely fabulous ambition. But I suppose I'm just wondering if there's anything the board can do to be helpful in either of our capacities, but as corporate trustee, to help with pace on this. Because we know every day there are families who would love to be using this resource, would be my first point. And my second is, and it is for assurance, I just would like to be assured that all sorts of schemes have been considered, even really simple, cheap ones, and pragmatic ones. I'm sure I can be assured of that. And then I've got a couple of people to bring in. So, Richard, what about the pace? Or is it Alison? Sorry. Go on, Alison.
If Alison does pace, I can do, have we looked, well, between us, we can look at, have we looked at all the options as well, can't we, Alison?
Yes. So, you know, it's tricky building up a scheme to deliver with the right finances in place. And obviously we were put back because of the increased costs. And that's the point where we had to start again saying, were we doing the right thing? So that's where we lost the pace, Mary. I'm now content that we have papers coming through to our private board meeting and for the December meeting, very much reliant on colleagues, particularly estates colleagues, to help us deliver this and to have all the up-to-date costs. So, you know, I am conscious with the Women's and Children's Build. This is a secondary thing, but also very important. And, you know, and that's what we've heard from patients, that actually this accommodation is still very much wanted.
Thanks, Alison. That's really helpful. Ella?
Yeah, my comment isn't in relation to the main appeal, which I know we are discussing later in private board as well. But my comment was more around, I know the work has got underway with fund holders, because we've discussed previously around the fact that in some cases we're holding funds and we wanted people to come forward with spending plans for those. And I can see there is a spending plan, I think of 840 or something in that region. I just wanted to know if we're kind of satisfied with that, or if that's what we expect, and if that has brought us into a place that we would require to be.
Richard, do you want to come back on the first point and then on Ella's?
Yeah, in terms of the first point, I am assured that we've looked at all the options. Indeed, we had the extraordinary meeting to make sure we considered all the options thoroughly, and we've got a preferred option and the fallback option if need be. I think because we've got a commitment to spend commitment for 1 million, it means that we need to follow through with that investment. Either we don't do the project, but if we do the project, we've got 1 million. And we need to spend it on something that involves a capital spend. So I'm satisfied we've gone through all the options. And your other point, Ella, I was a bit unsure what you were referring to. Were you referring to the wider projects?
Yeah, we've had a workshop, hadn't we? And we were asking holders to come forward with spending plans or proposals for the committee to consider.
Alison and I have discussed this and whether we need to have another session that brings together stakeholders to give everyone an opportunity to look at their plans afresh and be assured that they have got the support from everyone in the trust to make that happen. At the same time, we are very aware that some plans have been outstanding for a while, and we're reaching the conclusion that at some point we need to say, actually, you've had long enough to submit your plans and we can't wait any longer. And the last point was that there's a number of things that came up today around organ donation and research, and maybe there's an opportunity for us to go out to people more proactively and say, we would like to support you in this area, and work in a more proactive way to pull those plans together. And there is also an outstanding action that we had last time that is about whether we could use charitable funds to support our wellbeing work. And I think that's something that we need to put back on the agenda as well. So I'm saying that I think we need to be a bit more tight about how we manage them, whilst manage those projects, whilst giving everyone the opportunity to participate and perhaps look at alternatives when they can't.
Thank you, Richard. Ian and then Alison, and we probably ought to draw it to close there.
Yeah, just very quickly on that point around the spending plans, Ella, we took a paper to the last committee meeting, and we've got a follow-up paper coming to the committee meeting next week for charitable funds. So that's absolutely part of the focus, and we're seeing an improvement in that. But as Richard said, we're going to be considering next week what further steps we might need to take.
Thank you, Alison.
Yes, and just to add a little bit of detail on one particular area, which is the Mermaid Centre. Karen is leading a major piece of work, working with clinicians and the Duchy charity to try and pull together the two pots of money, because this is a long-standing, unresolved issue, which again involves what we do from an estates perspective. Thank you.
Well, that's very good to hear, Alison, because as you know, I do regularly have inquiries about that one. So that's really good to hear. So if there aren't any other points, we're asked to note the report from the September and extraordinary October 24 meetings of the Charitable Funds Committee. And we note that there is further work happening with that committee, and we'll hear back in December. Thank you for that. So we move back into being our own RCHT board now, and ask you, Adam, please, for your report on the Audit and Risk Committee.
Okay, thank you. I'll try and be succinct. This is a assurance report on the October Audit and Risk Assurance Report. 3 items in particular to bring to the board's attention. Firstly, the committee were assured with the actions and learning in place and being put in place to address the breach in standing orders, financial instructions and scheme of delegation, which we reported to the public board last time. So we were assured about that. That was a good piece of work. Secondly, whilst recognising progress has been made, still a concern addressing the outstanding actions from the 4 limited assurance internal audit reports, which, to remind everybody, relate to loan working, review of executive on-call arrangements, secondment arrangements and fire training compliance. So further work is ongoing on those, and we're expecting feedback to committee members and reports back to the next meeting of the Audit and Risk Assurance Committee in January. And thirdly, we've discussed a few times in this board meeting to flag a concern to the board around lack of progress on priority business cases. And we've kind of discussed that from a number of angles in this meeting already. Other areas to bring to your attention: the nationally prescribed audit of workforce controls has now been completed. That's touched on in the report. So that's good. A good piece of work has been done on internal audit on that. And there's 2 other items on our agenda today that we took full assurance on: the emergency preparedness report and the report on amendments to standing orders and financial regulations. And I will stop there, Mary. Thank you.
Thank you, Adam. And again, thank you very much for the work that you and your committee do for us in this very important committee. Are there questions for Adam on his report?
I think Ian has a question.
Thank you, Steve. Ian?
Thank you. Yeah, not specifically a question for Adam, just to pick up on 2 of those items of escalation to board, if I may, Chair. So at the pre-meet for the next Audit and Risk Assurance Committee in January, we had a good discussion around the limited assurance reports with Lindsay as well as Company Secretary involved in that. And we've subsequently since met with internal audit leads and established a process which we'll be following to make sure that the reports that come to that committee have had essentially a completed template, which we're just refreshing slightly to address some of the issues that played out at the last Audit and Risk Assurance Committee. and also that there'll be a meeting with the executive lead for each of those limited assurance reports with internal audit in advance of the committee, so that we can make sure that the committee is receiving succinct and assuring updates on those key areas. Bearing in mind they are limited assurances, we reflect on that. That's a serious issue for us as a committee with Adam at that pre-meet. So just to reinforce the steps that we're taking to make sure that we're in a much improved place with our internal audit colleagues and executive leads ahead of the January Audit and Risk Assurance Committee. And then on the last one that was raised on that list around the progress around priority business cases, so that was raised and is an action from board in public, I think, from the last meeting. We've been doing quite a bit of work behind the scenes, so just to reassure colleagues that that's not been forgotten about in any way, shape or form. We've been working through with the exec leads for each of those 7 business cases to understand what mitigations have been put in place, what we've got in our current financial run rate of your spend year to date, where we've had to put in mitigating actions, and what the further requirement is from the original business case that was put forward, and what options and how we might prioritise that. So that's a complicated piece of work, and it's a difficult piece of work in terms of the prioritisation element of it. That's now going through our. We had hoped we'd be able to bring it through Finance and Performance Committee last week and into this board meeting, but unfortunately that wasn't possible with leave over the summer, etc. So that will be coming to our executive leadership team through the normal process, and then to Finance and Performance Committee and board in private next month. So just to give a timeline, a clear timeline for that piece of work and update.
Thank you, Ian. That's really helpful and it is assuring. Thank you for that. Anybody else like to raise anything further? Okay, thank you. In which case we are noting the matters for escalation as outlined by Adam, and note the report of the meeting of the Audit and Risk Assurance Committee for October 24. And then item 16.1 is the Emergency Preparedness, Resilience and Response Annual Report, and that's Rob.
Thank you, Chair. So we have an annual assessment undertaken by the Integrated Care Board's EPRR team of the 62 core standards that we're required to have in place. And colleagues will note that we were compliant on 60 of those standards, and there were 2 that we're not fully compliant on. And those 2 are interrelated, and they relate to our ability to use a decontamination facility. And I'll apologise to the board and members of the public reading the paper. We didn't describe. So CBRN is chemical, biological, radiological and nuclear, and hazmat means hazardous materials. We are, as all NHS trusts, we have a requirement to be able to manage a decontamination event if required. We do have that capability. We have a tent that's available to us, but that tent has been described as been assessed by through its maintenance regime as only having 5 uses left in it. Therefore, we can decontaminate if we need to, but so that's one of our non-compliance areas because of that risk, and because of the position of that unit, we are not undertaking training to put the unit up and take the unit down, because that would constitute one of its life uses. Working with Ian and team, the intention is to use capital slippage to be able to replace that item, and the assessment is content with that approach. And that's one of the things that Ian was alluding to in the capital report earlier. So to reassure colleagues, we are fully able to undertake our requirements. It's just we're cognizant of that unit is becoming closer towards the end of its life. Thank you.
Thank you. Thank you very much. Any comments or questions? Ian?
Yeah, I've just popped in the chat just to follow up from what Robin said. On page 340 of our pack, we highlight the 2 potential options for that decontamination unit. It can either be a replacement of the existing tent, or it can be a standalone permanent unit that locates on our site. You'll see in the report there's 2 costs for that. They are significantly different costs. We've benchmarked regionally of what other hospitals have, and there is a mixed economy of the kind of static, what's essentially kind of like a shipping container unit that exists permanently, versus a tent that you have to take time to erect in the event of an incident. So the preferred method for the team would be the unit, but clearly that's significantly higher cost. So what we wanted to do was make that decision when we've got a clarity of our capital position. The lead time is relatively short, at kind of 8 to 10 weeks for either solution. So we'd be able to enact either solution ahead of the end of the financial year. And as Robin said, we've currently got a tent that is functional, but it's only got a limited number of uses left. So just to triangulate that back with that paper.
Thank you. That's really informative. Adrian.
Yeah, not really questions. 2 points, Chair, if I may. Firstly, with the equipment, I was a National CBRN Gold Commander and Hazmat Officer. So if you want any assistance when you're looking at options for decontamination, I'm happy to help. And in relation to staff training on decontamination, it might be worth speaking to the local fire service, because they do undertake training in that type of subject.
Okay. Thank you, Adrian. Okay, colleagues, enough on that one. So we're asked to note the 2024 EPRR core standards assurance process has 62 outcomes. Trust fully compliant with 60 of those and partially compliant against 2 with clear action plans in place. And to note that the EPRR committee would monitor the 2 partially compliant standards until fully compliant and provide assurance back to Audit and Risk Committee. So if you could please note those, and we'll come on to Lindsay, the Board Assurance Framework Report, please.
Thank you, Chair. So the Board Assurance Framework BAF is presented at every public meeting. Individual elements of the BAF are discussed on a monthly basis with the executive leads and also at the relevant committee meetings. The report is made in track changes for ease, but I will draw out a few things for the board's attention, particularly following the last board meeting in September, where we discussed a few matters which have now been included in the Board Assurance Framework. Particularly Board Assurance Framework 1 around safe care. We include a new gap in assurance relating to the concern about the ability to deliver the maternity CNST Year 6. We've talked about that today at this meeting, and obviously mitigations are in place and a report's coming through to Quality Assurance Committee. We also had an additional gap in assurance relating to the ability to deliver the 7-day services framework, which is due to time to consultant review. Actions are being taken again through Quality Assurance Committee to seek assurances, and there'll be a re-audit, which is coming back in December. With regards to BAF Element 2 on workforce, there's an inclusion of a new gap in assurance relating to the development of our OD and our culture, and actions are being taken. And we've had some recent excellent events around solidarity and helping support our staff be in an open and honest and safe environment. There's also an additional new gap in assurance relating to BAF 3, and that sets out the requirement, that's integrated services, sets out the requirement to understand the developing commissioning intentions. So we've changed slightly the actions that we're taking around that and the development of those which are ongoing. And lastly, there's a couple of new gaps in assurance regarding BAF 4, which is our finance, and we've talked about these today actually, which relates to the national pay for Agenda for Change, VSMs and junior doctors. As Ian pointed out earlier on, that we have mitigated that risk down further, but obviously there's still a little gap there. And then we've talked a lot today about women's and children, and that the Women's and Children's Hospital Programme linked to the engagement with the new hospital programme, and that will be under review on BAF 4. And lastly, new gap in assurance relating to the modelling for 24-25 and our financial position relating to SASH. So that's the St Austell Surgical Hub, and that's under discussion at Finance and Performance Committee. I won't go into any more detail, Chair, but please do note that there are a number of actions for the board to take today, which relate to the proposed closure of some of the actions where we have sought assurance, and these have been through all of our committee meetings. Thank you.
Thank you. That's really succinct and clear. Thank you very much. Are there questions? I know the committees have all looked at this. Anybody have questions? No? I don't propose to read out all of these. You have them in front of you. We're asked to receive and note the report and then to approve various of the elements as laid out in front of you, but I'm not going to read them all through, if that's okay. So if colleagues please could note your approval and also of the closure of gaps, as well as the one that Lindsay has alluded to. We will move on to 16.3, which is the corporate risk register. This is a starred item. I haven't had any questions prior to the board, and so we are invited to note there were no new risks on the corporate risk register. One risk decreased in score and was removed. One risk was closed in July 24, and the current, we're asked to note the current position with the emergency department risk 9048. So there were no questions. So if you could please make those further notings. 16.4 is also a starred item, which is a proposal to change standing orders, standing financial instructions and the scheme of delegation. There haven't been any questions about this, and so we're asked to approve the proposed amendments to the standing orders, standing financial instructions and scheme of delegation. On 16.5, a further starred item, the use of the trust seal biannual report. I haven't had any questions, so we are asked to receive and note the use of the trust seal, use of the trust seal biannual report for May 24 to September 24. And that brings us to the integrated performance report. And before asking Rob to take over, just to explain, we spend quite a lot of time, Stephen, Lindsay and I, trying to get these agendas right. And as everybody knows, it's not easy. And we've experimented with putting the IPR later, much later in the agenda this time, because we've noticed a few times recently, we're actually covering quite a lot of it in our debate about the papers, but this might not work. So apologies, Robin, if it doesn't, we can review it. But if I could ask you, please, to take us through that.
Thank you, Barry. I think it did work because we've been crossing things off my list all through the meetings. So I was to highlight Steve's report covered most of the urgent care, elective, cancer performance figures. I will draw colleagues' attention to our diagnostic performance at 83%. Back in the summer through the committees, we were supported by the committees and we said we had a recovery plan, and the committees have the committees being Finance Performance Committee and Quality Assurance Committee. And you can see the graph has been delivering that recovery plan as stated. And I would just acknowledge again, the Quality Assurance Committee and Finance Performance Committee in particular undertake a considerable amount of scrutiny on this report. Of note is our stroke rating has moved to SNAP-C, and SNAP stands for Sentinel Stroke National Audit Programme. That's a standard that we should all be aspiring to. We are aiming to be B rated and above, but C is considered to be the minimum standard, and we've moved up from the D. So we should acknowledge that work from the team. You will see in the IPR there are a number of metrics that we would want to see better, but we should still acknowledge that improvement. We've talked around the NOF issue, fractured neck of femur, through today. On the day cancellations is worth drawing to colleagues' attention, is at 1.34%. And we've described previously that our method of operating a function is we don't cancel the day before. We aim to bring people in for surgery. With our operational pressures, if we were to cancel the day before, we would have significantly impacted our elective activity. The consequence of that is there are on occasions where we do unfortunately have to cancel patients on the day. And I would just draw the board's attention to October has been a particularly challenged month for us, and the next time we look at the IPI, you're likely to see that number have increased slightly. I was going to note that occupancy is up. Our average length of stay is down, as we've said. Our delays, and those are the patients on those pathways 1, 2 and 3, are up at 108 on average, which is significantly above our target of 56, which we've talked through the linkage of that, but thought I would share the numbers in the report itself. And one thing that we do pay close attention to with our drive for discharge is our readmission rate, and colleagues will see that our readmission rate has gone up now to 8.18%. and we are cognizant of how we get that balance right of discharge against readmission, and we do that triangulation piece through the integrated performance report. At this point, I would normally go round the room, but I'll just acknowledge that it's day 4 or 5 for Mary, so I'm not going to say, is there anything you want to add, Mary, from a medical director's perspective, because it's covered in quack? And I was just going to see if Kim or Alison wanted to put their hands up, Mary, and that would speed up this section.
Could I just be clear that that 108 is a system target?
The target for RCHT is to be at 56 patients on a pathway 1 to 3, and the average in RCHT was 108. So those
So the
are
target is 56, but we're
for RCHT. Yes.
Target then progressively reduces from January next year. So we had an improving trajectory, and I think that improves to 44 for January, February, and March.
Do we need to do a reality check on that?
We monitor that every single day, and that forms part of the our internal review, but the System Control Centre system-wide review.
Thank you.
As mentioned earlier, the discharge event 25th of November will be the whole system coming together to try and support recovery to that trajectory.
Thank you. Kim?
Just a quick one, and we discussed it in quack, but it's important to note the board will know that we've got a multi-professional, multi-stranded piece of work being done on our C. difficile rates, and we note that our tolerance remains high, but it's really important to note that nationally there's been an increase of 33% in C. difficile rates. So we are not complacent. We are closely linked into networks to be able to learn, but it is going to be a national focus, as it should be. And early trends are older people, deprived communities, and we can definitely see that we fit that criteria, but we won't take our foot off the pedal. We will work closely with, but I feel that we need to acknowledge that.
Thank you for that, Kim. Thank you. Are there any questions further for Kim? In that case, Alison, is there anything you would like to draw to our attention?
Very quickly, the workforce indicators are very stable this month, not much change. However, if you do look at appraisals and stat and man training and look at the trajectory that we've been on over the last 2 years, you can see that it has gone up in the right direction. Still not where we want it to be, but continually up. Thank you.
Direction. Thank you, Alison. Ian, do you want to say what you've put in the chat, because the members of the public can't see that?
Yeah, absolutely, Chair. It was just, I was particularly drawn, and I know we've been updated by Robin and colleagues on it regularly throughout the year, but on page 568 of our pack, it shows the incomplete pathways for 65-week patients over 65-week waits. And I just wanted to recognise out loud, really, the fact that there's been a lot of work from a lot of teams to get to that position. And I think we're doing well in comparison to our peers on that as well. And it's just such a steady decrease over that time. When you look at one point, we had over 1,600 patients waiting over 65 weeks at the end of the COVID period. So it was just to recognise that, because I know we mention it every time, but actually when you see it in that graph, it's a very steep downward trend, and is really important to patients that will be listening.
Thank you very much. I agree with you, and I've used your analogy several times, Robin, when you were telling us how many thousands of actions had been taken place to get to that, and so we do want to acknowledge that. Thank you. Thank you, Ian. Anybody else? Okay. We are then asked to have discussed for assurance the month 6 performance under those domains of safe, high quality care, supported and valued people, and our journey of improvement. And we come to the summary considerations of the risk, please. Not just you, Lindsay, but you can kick us off.
Thank you, Mary. We've considered a number of different areas today, and so I'll just talk through some thoughts. We talked particularly around our harm review. Our Quality Assurance Committee do have oversight. However, there was a lack of progress, and that has been reflected on the BAF. But just to raise that, particularly as well, fracture neck of femur, we noted around the perfect week and the negative trends, but we have seen, and we will continue to see this through our Quality Assurance Committee, and it is reflected on the BAF, but we will consider that at our next review meeting. We talked about our OD plan and the good programme, but obviously there was concern around our pace. Again, this is reflected within our board assurance framework, but we'll have a further consideration of that. We talked, Ella and I actually talked during the break earlier on around research and development. We don't really currently cover that through our board assurance framework. However, we've considered in the round of our transformation and our direction of travel towards being a university hospital and having a medical school, and actually so we're going to consider that in the broader enablers and how the risk of not delivering that will potentially have impacts. We talked around agency and improved positions, but obviously we're still not seeing that movement, but that links with our operational pressures and our concerns around obviously our financial position. We talked about women's and children's programme, again reflected on our board assurance framework, but we will consider to monitor that. We talked about the prioritisation of our business cases, our key business cases, and that is something that's ongoing, but we can reflect that in the board assurance framework with regards to delivery of safety, quality of care. And then there was only one other risk, I believe, where we talked around sexual safety and safeguarding, and we talked about foot-through and engaging colleagues together, but I think that is reflected on our board assurance framework. But again, with our general reviews, we will pick up some of these key things, I think. I'm happy to have any colleagues comment further.
And any colleagues who'd notice any other that we might have missed? Kim? Kim?
It's not, not missed, but we might just want to review our occupational health risk with Alison, Lindsay. I know, I think there is a risk on the, there is a risk, but I think we just need to review it.
Thank you for that, Kim. That's helpful. Anybody else notice anything? No? Okay, thank you very much for that. So we have identified those risks and where we're going to cover them. So we now come to the section where we have questions from members of the public. So thank you very much for your patience in waiting till we get to this point. I'm going to ask Lindsay, please, to read out questions and to ask an executive to respond.
Thank you, Mary. We've had 3 questions over the course of the day today. All 3 questions are from Jane Burnell. Jane asks, question 1, is there a trade-off between rapid discharges and readmission rates? And I'm going to ask Robin to come to that question. Thank you.
Thank you. I'll cover that in the IPR as well, Jane. So you've got the numbers from us. Yeah, there is the trade-off, and we're always aiming for a safe discharge, which should limit the likelihood of emergency readmission. And as you can see, we track it openly in our integrated performance report.
Thank you, Robin. Question 2, again, I'll come back to Robin, which is how are patients and their families involved in the design, production and delivery of virtual wards?
Jane, so the virtual wards are actually delivered by our colleagues in Cornwall Foundation Partnership Trust. So I couldn't describe the production of the wards and the relationship with involvement with patients. But what I can assure you of, Jane, is that in a discharge discussion, if a patient is being discharged to the virtual ward, there would be a discussion with the patient and, if they consented, their relatives for what that would look like and what that would mean. They would be very much involved in that journey.
So it's an individualised. Yeah. Thank you.
Thank you. And the last question raised by Jane is, what proportion of people classified as no criteria to reside are waiting for NHS services from RCHT or other providers?
So it's easier for me, Jane, to give you, I can give you a live position when I looked this morning before I came into the room. So this morning we had 658 inpatients, of which 107 patients were no criteria to reside, which is 16.3% of our bed base. Of the 107 patients that were no criteria to reside, 5 were on a pathway 0, which are for RCHT to make sure that we make those discharges. And those patients were in our discharge lounge, which is where we would expect them to be.
Thank you. That's the last of the questions.
Thank you. Thank you very much to members of the public. We really do welcome your questions. That brings us to item 20, which is the item where we review the effectiveness of our meeting against a number of criteria. But I'm so sorry.
No, Madam Chair, sorry, apologies. I thought before we moved on to that, I'm going to ask you forgiveness because I'm going to do something that's not within our protocol and just ask for another item of any other business, please, just to be injected at this point. I'll ask for your forgiveness because it's not an item that you'll probably like, so we'll do it. You kindly and very appropriately warmly welcomed David as chair, who will take over in the early part of January, which I believe means that this is your last chairing of the board in public. And I just wanted to we'll have plenty of chance to say goodbye over the forthcoming weeks and give you our opinions of thanks and gratitude. But I just wanted to give people the chance now to reflect on your sustained leadership and guidance and your absolute commitment over the time you've been with us to Royal Cornwall Hospitals Trust. And that time has been approximately 11 years as a non-executive director and approximately 6 years as the chair. Throughout that time, the Trust, and I believe the population that we serve, and I know you very much see this as a service. I think we would want to express our very deep gratitude for all that you've done for the Trust. You've provided a clarity of vision. You've provided determination to deliver to the highest level of care for our population of Cornwall and the Isles of Scilly. And I think throughout that time, you've truly embodied all of the Trust values of respect, compassion, honesty and teamwork. In fact, I think you're probably one of those people that if we cut you in half like the stick of rock, they just run through you. So you've led the organisation through great challenges, but also through great achievements. And so I just wanted to say on behalf of the board and just for now, thank you so much.
Richard, thank you very much indeed. That's really, really valued.
And Mary, if you don't mind, if I could just follow on from Richard's comments. Mindful that we're in a board in public setting, there'll be many members of the public who perhaps don't really appreciate the role of the chair of a board, and quite likely a number of our colleagues who work within our organisation who don't necessarily appreciate and understand the role of a chair of a board. The chair's primary responsibility is to lead the board, and the board has 3 main responsibilities. The first one is to set the strategic direction of the organisation. The second one is to set the culture and the tone of the organisation. And the third one is to assure and ensure the delivery of our plan each year. And I don't say those things lightly, as Richard's just touched on, that there are some exceptional challenges facing our organisation over previous years. You've led the Trust through the extraordinary challenge of the COVID pandemic. And none of us could have foreseen the nature of the decisions that would be necessary in a COVID pandemic, but you've steered us through that. You steered us through some really significant NHS organisational change with the establishment of integrated care systems, integrated care boards, and you've navigated us through the emergence coming out of COVID into an environment of really very, very demanding operational pressures. But we've heard some of the fantastic successes of improvements in elective performance and access. And of course, you oversaw one of the largest improvements in the country in staff survey results last year, as seen through the NHS annual staff survey. And as Rich has already said, you've done all of those things with respect, with compassion, with honesty and teamwork. So I'd want to echo those thanks on behalf of executive colleagues, but on behalf of staff right across our organisation to say thank you for everything you've done for us. Thank you.
Thank you. Thank you both. Thank you very much. It's really, funnily enough, I did say to Robin in one of the breaks, I probably wasn't going to get through the next few weeks without the odd tear. But thank you. And it's fascinating to me that I was chairing a board in this very room on the morning that I was then interviewed for the chair role in the afternoon. And it was very odd coming back into the room and sitting down, thinking, no, I need a different seat. I can't sit in the same chair. Thank you both for your incredibly generous words. It's just been an amazing privilege. And that word, well, all our values, but that word teamwork, as I think today has illustrated, we are a team. We don't get through this without everybody playing their part. And I think we've heard that. And I think we really do work respectfully and honestly with each other. I think we've been really good at disagreeing agreeably, and not everybody is. I think we have that to a fine art, really. And I think the respect we have for each other is part of what makes us able to disagree, because we're doing it for the best reasons. So I shall stop there. But thank you so much. I really value what members of the public and members of our staff do in giving their time to look in on our board. And I think the work that our staff do in particular is remarkable. So to make time also to look at us talking about what we do, we really value, as we value our members of the public. So I'll thank you very much indeed. And now we'll see how we've done. Thank you. So we want to say what went well, what would have been better if we had done. Have we been consistent with our etiquette? Have we contributed to patient safety? Have we considered health inequalities, our triple aim? And are there matters we need to communicate? And I did give 2 of our newest members warning in advance, so we will be expecting to hear from them. And I have said to David we'll hear from him, because he's here as an observer today. We'll hear from him in the private board. So, but you 2 don't have to start. Please don't feel obliged. Isabel's usually good at starting. Oh no, it's going to be Rob today.
I'm just going to say I felt it worked really well to put the IPR at the end, because it shows how our whole board conversation weaves its way through one of our most important documents and brings it all together.
Thank you. It did. Yeah. Ian.
Yeah, I'd echo that comment. I think it worked well having the IPR at the end as a test. I welcomed colleagues' feedback on the changing report. I think it's good that we're ambitious to change our reports and try different things and see how that works. My other point was around the breaks. I thought 3 breaks in a meeting, so this is going to be nearly a 6-hour meeting since we started. 3 breaks worked well. Personally, I think we could be more kind to ourselves and have a longer period at the lunch break. Because I think when I totted it up, we're talking about 40 minutes of break in a 6-hour meeting. So I don't know about others, but I felt like grabbing a sandwich in 15 minutes was a challenge. And so just to reflect on that. But yeah, really good meeting.
Yeah, very well played, Ian. Thank you. I've got Mary, and then Isabel, and then Matt.
I'd like to comment on something that you're all probably quite used to, but I'm not, in that it's a public board broadcast, and therefore it attracts many more attendees than the boards that I've attended before, where you're lucky if you get 1 or 2 people because they have to make the journey. It changes the conversation. It was very much more patient focused. The language was better. The language was accessible. I felt that there was a lot of compassion in the conversations, whether we were talking about the patients or the staff, and that came through in nearly every paper that was presented, which is, hugely positive and absolutely aligns with the culture. I think, the H in RCHT around honesty, I think it was a very honest meeting, and I think that's a real positive in terms of bettering ourselves. What else did I write here? I've got a couple of things. I think the other thing I'd like to bring out, and it was beautifully done with Lindsay's summary at the end, is by the end of the meeting, I felt that it was very clear that everything we had discussed was aligned with the BAF. You don't always see that, which means that everybody in this room is aware of the BAF and is on it in terms of its currency, and I haven't always seen that before. So they're my comments.
They're really helpful comments, and fresh eyes are so important to us. So thank you very much. And actually, we did a fresh eyes review with our new non-execs last time. You might like to have a look at that paper, because fresh eyes are a wonderful thing. So thank you. Isabel?
Yeah, I think it's been a really, really good meeting. I think the breaks in it have kept our reserves topped up, and I think that's made a big difference given the amount of time that we've all been in the meeting together. I think the other thing for me is that it's always really heartening to see the quality items ahead of the finance items. Sorry, Ian, and sorry, Richard, because I think for me, that just underscores for me the importance that we give as an organisation and as a board to our patients and to our staff. So I'm really pleased to have seen that. Extremely well chaired. I'm still a bit choked up listening to the speeches, Mary, but I guess there's going to be a few more of those to come before you go. But excellent meeting, and I'm really sorry I couldn't be there in person to meet our new folks that have joined us, but I look forward to doing that soon. So thank you, really good meeting.
Thank you very much indeed, Isabel. Matt?
I think my overarching theme of how it's felt, so there's been a warmth within the room, the respect for colleagues, but with a healthy challenge about how we do the best that we're here. But I think that warmth really comes out in the compassion, and that flows through into the focus on the patients as well and those who we care for. I think it was really, really heartening to hear that we focus on doing the right things, the best things, then the other metrics will follow, rather than being driven the other way around, particularly with some of the pressures that are being applied system-wide, and the budget may play into this as well. But I think the bit for me has been the welcome and warmth into the team. So just like to thank you all for welcoming me in.
Thank you, Matt. Really helpful observations, because, as I said, it does make a difference, and we are never complacent, but it's always good to have that fresh eyes on us. Thank you. How are we doing? We've done enough? I think we have. I think we've done really, really well. The date of our next meeting in public is the 7th of January, which coincides with the first day of David, and David will be chairing the board. So there you go. And colleagues will now take another short break before we move into our work in private. And so thank you to everybody who's attended today. Can I suggest, colleagues, what time is it? 10 to? Should we just take another 15-minute break and keep going? Is that okay? Right, so if we kind of get together again at 3:05, that would be wonderful. Pete, thank you and your team very much, as ever. Thanks a lot, everybody. Bye-bye.